ones do carry on with the regular activities. Mild cases often asymptomatic. The severe cases lead to repetitive microtrauma, accelerated damage to the cartilage and reticle, eventually leading to degenerative changes. Coming to common types of FAI, there are basically three types. One is a cam mechanism, cam type where there is a bump on the femoral head which rubs against the acetabular labrum. Second is a pincer type, and third is a combination of these both. Coming to the cam type, cam is normally used in the engineering this thing. It converts the rotatory movements into axial movements. So basically it's an abnormal bump which appears onto the abnormal bump which appears onto the femoral head. It is gone out of the focus. And normally the anterior superior area of the femoral head is involved. So whenever there is abduction or internal rotation or flexion, in the flexion and internal rotation, this impinges onto the acetabular wall. There is a resulting spasticity and supraphysiological stress leading to cartilage and labral tear. Coming to the pincer type, this is how a pincer looks like. Normally we see cobblers using the pincers. The acetabular bony overhang, normally over anterolateral, or it could be overall acetabular overhang with calcification of the labrum, which overcoverage of the femoral head results in the cartilage injury. And whenever, if it is very severe, there is quadricup injury because the superior overhang of the acetabulum forces the femoral head inferiorly. So there is inferior cartilage loss also. Mixed type, this is the most commonest type. There is existence of both the etiologies. Coming to the etiology, we do not know what exactly causes this, but there is definitely a genetic correlation. Athletes and high intensity workout, those people who result in do high intensity workouts are more susceptible to FA, especially the CAM type. Rest of the causes, as we saw yesterday, are untreated or fixed slip capital femoral epiphysis, septic sequelae, Perthes, DDH, sometimes avian resulting in collapse, and extra bone, the bump due to cam deformity causes impingement. And post-traumatic causes, especially if there is a malreduced acetabulum fracture, or especially the ABC type of fracture, which results in secondary congruence, causes a pincer type of avian, FA. Coming to the clinical presentation of it, if other than the asymptomatic patients, most of the patients do complain of pain in the anterior groin area or hip pain. The pain is more severe whenever they are doing high intensity activity, especially squats, lunges, or sometimes if it is severe, it is difficult while the patient is in sitting position also. The mechanical hip symptoms especially present whenever there is a labral tear, the clicking and popping will be seen. Sometimes the gluteal or trochanteric pain also could be felt due to altered biomechanics and increased muscular tension. The clinical examination, suspect a FAI, first you need to analyze the gait, whether there is any lurch or whether there is any gluteal lurch or abductor lurch. The range of movement needs to be assessed. Usually the hyperflexion, the extremes of flexion and internal rotation will be restricted. The strength needs to be assessed because decreased range of motion could also lead to decrease in the muscle strength. And important test is to flexion, adduction, internal rotation test. This is for the anterior cam type of impingement. Whenever you are doing a force flexion, adduction and internal rotation, there will be a pain. And if you are suspecting a labral pathology, flexion, abduction and external rotation leads to elicitation of pain. And in posterior impingement, and posterior type of impingement, you'll have to do a hyperextension and external rotation test, which leads to elicitation of pain. Coming to investigations, we go stepwise. It's radiographs, CT and MRI. MRI usually quantifies the labral damage and cartilage damage, and CT we usually go for it if you are planning a surgery or a correction of the deformity. Usually the radiographs are sufficient. So this is a pelvis. The basic radiograph is a pelvis AP view taken in maximum internal rotation possible. Usually there is a bump. We are able to see a cam type of deformity with ectopic bone formation down here. It appears like a pistol grip. A second view is focused views. Coming to focused views, the done view or a modified done view. In done view, we flex the hip to a 90 degree and externally rotate the hip by 20 degree, and we take a X-ray. But usually 90 degree flexion with external rotation of the hip is usually difficult. So the modified done view with 45 degree of hip flexion and external rotation is used. This is how the X-ray looks like, and you'll be able to see the anterolateral part of the head much better, and the pincer this thing, if there is any acetabular overhang also, it will be seen better. Coming to another view, the false profile view, this is how you position the patient. Usually the patient is at a 65 degree angle with this thing, and you focus the beam from this side, the X-ray beam, the cassette is here, and this is how the view looks like. It is especially used to see if there is any anterior impingement or anterior overhang on the X-ray. This is our pelvis view. These are the common signs which yesterday Dr. Srikanth spoke about. The gunstock deformity or the pistol hand deformity, handle deformity of the cam mechanism, and the crossover sign, especially when there is increased overhang and acetabular retroversion. Coming to few of the angles, these angles, like at the first glance, becomes difficult since we are not used to measuring these angles on a regular basis. This is somehow similar to the distal end radius, the acceptability criteria which we used to study very regularly. Over the period of time, these angles get inculcated in your practice. So you need not measure the angle every time, each and every time, but looking at the X-ray, you should be able to make out that this is. The first is the alpha angle, normally taken in a lateral view, a dead lateral or a frog-leg lateral view. Basically, you draw the center of the femoral head and the center of the neck, and you draw a straight line. And the second line is where you trace the head from the center. This is the most spherical part. You trace the head from the center till here. Wherever the head loses its sphericity, that is the second point. And the line connecting these two, the angle between these two is the alpha angle. Normally it is less than 42 degree. If at all, if it is more than 42 degree, then it becomes, if it is more than 42 degree, then you should suspect CAM type of impingement, FAI. Head neck offset ratio. This is in a true lateral view. You draw the center of the femoral head and draw the center of the neck, that is the long axis of the femoral neck. The second line is along the leg. The advantage of drawing this line is the other lines should be parallel to these lines. So the next line is along the anterior border of the femoral neck. The third line is at the point of the maximum femoral head, wherever the femoral head is the maximum bulge, that is the line. And then you measure the distance between this, the line 2 and 3. These two lines, we measure the distance, that we will consider it as A. And B is the diameter of the femoral head. So normally A divided by B is more than 17.017. That is normal. If it is less, that means to say if the femoral head is here, if there is a CAM type of impingement and the femoral head comes somewhere here, the A distance increases. And whenever you divide by it, it decreases by this thing. It should be at least 0.717. The lateral center edge angle. So this is taken in an AP view radiograph. Yesterday it was explained, I'll just go through it once again. You draw the center of the femoral head and draw a vertical line. And then you draw to the edge of the bony edge of the acetabulum. This is the normal angle. Normally less than 30 or 33 degrees is considered normal. The thing of lateral center edge angle is it is described in DDH. We need to understand whenever this angle decreases, whenever the bony roof covering decreases, that means there is acetabular dysplasia. The angle decreases. If there is significant decrease in the angle, it goes towards the dysplastic side. And if there is extra bone formation, and if the bony edge overhangs, if the angle is increasing, then it leads to, it signifies impingement of femoral acetabular impingement. The anterior center edge angle, this is taken on a lateral view. This also signifies the same thing. Normally the center of the femoral head and the anterior edge. Normally it is around 25. If it is too less, then DDH. If it is overhanging more, then it goes towards femoroacetabular impingement. And the tonus roof angle. This is normally a parallel line at this and then the edge of the angle. It is usually 0 to 10 degree. That is the usual range, 0 to 5 degree or 10 degree. If it increases, if the tonus roof angle increases, then it signifies DDH. And if it goes into negative, means if this line is coming, if the acetabular roof is hanging till here, if it comes into negative, that signifies impingement. So these are the basically whenever the angles increase, except in Tony's roof angle, it is the impingement. Whenever they decrease, if you go into lateral central roof angle, the angle increases, you are going into FI, femoroacetabular impingement. If it decreases, we are going into DDH. Similarly, with respect to anterior central edge angle, if the angle increases, it is impingement. If the angle decreases, if we are going into dysplasia. But in Tony's roof angle, if the angle increases, we are going into DDH. If it decreases, then it is because of the over coverage, then we are going into a femoroacetabular impingement. So we need to consider some of the differential diagnosis whenever we are looking at a patient with FAI. AVN of the femoral head, hip dysplasia, iliopsoas tendinitis, greater trochanteric bursitis and gluteal tendinopathy, iliotibial band syndrome and snapping hip syndrome, and lumbar radiculopathy. Most of it will be able to delineate with a diligent clinical examination, but with the help of MRI, the added MRI and X-rays will help you out to arrive at a diagnosis. Coming to the take home, the severe cases, it is very hard to miss because it's very hard to miss the elephant in the forest. It is staring at you, you will be able to pick it up. The initial stages, always unexplainable hip pain, patient coming to you with repeated activity, increasing with activity, always keep FAI as a differential diagnosis. Examine clinically and investigate appropriately. And it is difficult to measure all the angles in the daily OPD. You can inculcate, looking at the X-rays repeatedly will give you a judgment on to whether it is dysplastic or whether it is the impingement. Thank you.
Which angles you consider most important in diagnosing FAI? Because nobody is going to make these line diagrams every time the diagnosis.
Yes, sir.
In fact, people will ask for MRI or other investigations.
Yes, sir.
Right? When you look at the X-rays,
yes, sir.
What things to keep in your mind? Yes, this is FAI.
Sir,
for a beginner, so that the diagnosis is not missed.
Yes, so normally it is difficult to get all the views. One PPH AP view in the internal rotation and lateral view of the hip is sufficient enough to make a diagnosis. By looking at the X-rays repeatedly, at least we know that these angles exist. These are only to guide us, like we said, like in distal end radius, every time we used to remember the acceptability.
Clinical is more important.
Yes, sir. Clinical judgment, the X-rays are only to guide us if it is confirmation.
You are defining this Tony's angle, it is more, going in favor of over coverage, and
yes,
it is less is going in favor of DDH.
Yes, sir. Yes, sir. If the Tony's angle is more, it's going in favor of DDH. Sir. Parallel with this thing, the roof uncoverage that will lead to increase in Tony's angle. If there is over coverage, then it will go into negative, sir. So that will be in favor of femoroacetabular.
And the normal is you mean 5 degree.
Normally 0 to 5 degrees.
But this is difficult to define that.
No, it's very difficult to say. It means we need to imbibe all those angles into our the thing like
the certain sign like your crossover sign.
Crossover signs.
It is dependable one.
Yes, sir.
And any other, which is that is what I wanted to ask.
Sir, the piston. Normally we are used to seeing the normal femoral head. If the head is looking a bit oblong, or if it is not spherical as such, it is looking a bit oval, then we need to suspect the affair, especially in the posterior.
Very nice. Thank you.
Thank you, sir.
In older age group, what are the causes for impingement?
Sir?
In older age group.
Older age group, sir. So normally it is a combination of both fractures. Normally the osteoarthritis of the hip is not primarily seen, but we do see calcification of labrum in older individuals, especially. But they are mostly asymptomatic, especially with some minimal pain whenever they are in post-internal rotation. Apart from that, not much the things. So the primary osteoarthritis I feel is the most common this thing, the calcification of labrum part with degenerative changes. Apart from the causes I mentioned like secondary arthritis, post-traumatic arthritis, all those things. But mainly it is this thing. So, but most of it is subclinical. Sir. Most of the patients do not come to us with pain because there are X-ray, even with X-ray findings, most of the patients are asymptomatic. And without X-ray patient, some changes patients are, it depends on their need for the lifestyle. Means if they are leading an active life, maybe they tend to be more symptomatic. If they are going on with a regular life, then they are asymptomatic.
Yesterday, Dr. Mabu sir has shown some X-rays.
Yes, sir.
With the double heads.
Yes, sir. Yes, sir.
Without any impingement, and he's
Yes, sir.
saying that he is not having any impingement.
Yes, sir. Sir, one only clinical explanation I can think about is hinged flexion and hinged abduction at the defect. So where the head is getting pushed inferiorly.
That is
Because
very
the
commonly seen in late 30s.
late birth is kind of the hinged abduction, and maybe it is pain-free.
So, excuse me, is it more a disease of younger patients?
Yeah, to be frank, sir, actually, it came into picture basically in young athletes. Yes, young athletes. It started.
I think some kind of a microfracture situation is causing this increased bone formation and this bump.
Abnormal stresses around
That's what something like a
microfracture. Abnormal microfractures or micro delamination of the cartilage.
something
These people
similar to an
go
osteophyte
joints,
formation. Something similar to an osteophyte formation.
Yeah.
Repetitive strain injuries,
Yeah,
basically.
strain at a particular
Yes.
angle.
Yes.
Yes.
And you're talking about lunges and squats and all.
Probably taking a good X-ray is very important. Rather than taking an MRI.
No, I think the last slide, what the mind does not know, I did not see. I think that is the
So most of us are
best
not.
to take home there.
What happens is the X-rays are very important. The position in which they take X-rays are so haphazard. It's difficult for us to get an insight. Good discussion. Thank you.
Nicely explained about the contribution.
Yeah.
Nicely explained.
Santosh?
Yes, sir. Again, continuing the controversy, half of my topic is covered by Akash already, but I'll just run through the slides. But yesterday, yes, again, FAI came back as a review article way back in JAOS, long back around 2007, and from that time, it has been under discussion in India, and many people have been doing this. But I don't find a lot of people treating it as such, I mean surgically in India, because I couldn't find much papers from India, hardly to be frank, not a single paper as such, which shows like surgical treatment offered for FAI. And I have a very little experience, and whatever my X-rays or clinical pictures are from the internet, but I have been discussing at least from last 2-3 weeks with people who have been doing FAI outside, and they have come back to India. They say it is very less clinically presented in India, and even with senior doctors, which I discussed retrospectively also, after seeing the X-ray, when they go and examine whether those signs exist, they have not been able to correlate those signs. There's definitely a lot of we see a lot of care mechanism in our young people, especially young adults, but none of them are symptomatic. We would have taken that pelvis X-ray from something else. So the same controversy continuing again, radiographic evaluation, X-rays, pelvis AP, frog-leg ladder, and this done view or the modified done view what Dr. Akash was mentioning, it came into picture because the deformity of the cam, basically if it is very subtle, it is in the anterolateral part. And when you do a complete frog leg, again it gets missed. So the 45-degree flexion and a 20-degree of abduction without any rotational component is usually advocated for if you are trying to pick out a cam lesion. CT MRI again, more than MRI, nowadays the MRA is gaining preference because you want to look into the labral tears, if at all. I'll show you to the pictures. I just run through those. See, normal AP, as Dr. Srikanth also mentioned yesterday, what is the correct AP view? Again, it should be all centralized. And some books mention less than 2 centimeters, some mention around 3 centimeters from the tip of coccyx. And some of the articles mention from the sacrococcygeal joint, it should be less than 46 mm. That is what they mean, 4.6 centimeters. This is more important, and it should not be an inlet or outlet pelvic view. This is to decide that both the obturator foramina should be symmetrical. And in that, you basically look for something like crossover, which happens before the before the sourcil. The crossover should happen before the sourcil. If it is happening very near the roof, you don't consider it as a retroversion. And one more sign called as a posterior wall sign. Posterior wall sign shows whether there is an increased anteversion or a less anteversion when you find that the posterior border of the posterior wall should be at or lateral to the midpoint of femoral head. And again, same thing what Dr. Srikanth had mentioned yesterday, draw an ilioischial line, which is red one, and see whether if only the acetabulum is crossing that, then it becomes a profunda, coxa profunda. If even the head is going out, then it becomes a protrusio acetabular. And coming back to these CAM and pincer lesions, CAM lesions have been described more common in young athletes, adult males. And pincer lesions have been commonly found out after in the third and fourth decade of life of females. That is how clinical presentation has been shown. And we can't explain that, and they are not able to find out why this happens in these particular age groups. One of the reasons in middle age, if in India, we have seen a lot of, one of the findings is usually some amount of osteomalacia can give you a protrusio, but none of them complain of any pincer type impingement. Even though Indian females most of the times use Indian toilets squatting, never complain of any much pain. So we don't know whether it really exists in Indian scenario. So modified turn view, as I said, so there should be an abduction but no rotation. Here also there should be abduction only around 20 degrees and neutral rotation. Both neutral rotations are important. Since turn view is very difficult to get it done, and that is why the modified turn came wherein the patient can rest their leg, or someone has to support their legs, or you have to have a bolster here. So alpha angle, as Dr. Akash mentioned, same thing whatever he has mentioned, and also this is an offset ratio. And I was going through, there is a lot of controversy even in the radiographic findings. When I was going through the article trying to brush up and all, I came across an article which says now our recent value up to 60 degrees is acceptable. Older articles, as Akash has mentioned, 42 degrees, but now again 62 degrees is acceptable, and offset they calculate directly from the highest bump area to the head. And if it is less than 8 mm, they again consider there is an existing CAM lesion present. So still an MR, the controversies are still persistent. The MR, as I showed you, helps in detection of the primary and anatomic abnormalities on the femur and acetabular. And also the secondary things which have changes have occurred, like cartilage or subchondral bone changes, joint space narrowing and everything. And CT especially will help us in planning what approach is necessary. Is only arthroscopic sufficient for trained arthroscopy doctors, or they also have to do a safe surgical dislocation. So this is how a labral tear will look when you in an MRA. So MRA is more important in assessing our and also the cartilage injuries. If any cartilage fragmentation is occurring near the fovea or on the head and all, it will help us in diagnosing the problem, so that whether you can go inside with arthroscopy or you have to come and do a safe surgical dislocation. So again, CT MRI, you also have, sometimes you find chronic changes in the CAM or the impinging areas, the cystic changes. You have to be very careful when you are trying to shave this off. So modalities of treatment, again, conservative will include rest, which means basically preventing what all activities are causing your symptoms that have to be prevented. That is most important modality here. Medications, again, to prevent at least cut the vicious cycle of pain causing inflammation again causing more pain. Some anti-inflammatory medications will be helpful. Activity modifications, which our Indian scenario people are always ready to make. They can accept it rather than undergoing surgery. They always are ready to change their activities. In a Western world, it might be different. They don't want to do that. They want pain relief with whatever cost they are. Probably that might be one of the reasons where you are operating more FAIs in Western countries rather than in India. And rehab. And what does rehab mean, basically? Rehab, it should not just write a letter of rehab and send it to physio, because they will also not know what you need or expecting from them. So basically, you will have to assess, like in shoulder, what is the is there any capsular tightness, is there any posterior capsular tightness, or any movement is getting affected, or any hamstring muscles are tight, or adductors are tight, abductors are tight. So assess clinically properly, then go again and then write your detailed physio form. You just write physio, it doesn't work out, because most of the physios also will not be doing what to do. So you will have to tell them what you are expecting from them to do. Basically, most of the times it will be stretches of hamstrings will always be tight, even in athletes, because they are runners and they don't stretch them properly. ITP and tightness will also always noted. So basically, tightness of releasing these tight muscles and stretching the hips. Slow stretches are very important. And you always mention initial 1 or 2 weeks to be done within the limits of pain. If you do more painful, they will not follow. The patients will also not do it, and it also elicits more inflammatory reaction and more inflammation. You might get a synovitis. Fourth day, the patient will not come to physio, and they'll say the pain has increased, I will not do it. So these are important. And improve the soft tissue flexibility, same thing. And the more important muscles of the hip, like abductors are most important. So you need to strengthen them. They are like your quadriceps for your knee. So abductor strengthening is very important. We'll have to assess how weak are they, because any pain in the hip again causes abductor weakness. So progressive stretching and strengthening are important. Then proprioception or the neuromuscular control of the joints are very important in doing any rehab. Especially being an arthroscopy surgeon and managing most of my ACLs conservatively, because patients, they don't want surgery, I put them on a rehab and most of them do well. I even have a football player who came to me recently with some other problem, rectus strain. He is a professional playing for Boca Juniors. He said he had ACL injury 2 years back and is not getting operated. And he's playing football regularly. So it doesn't mean that every pathology in a human doesn't, if it is seen on MRI or an X-ray, doesn't need treatment. No, you have to assess them clinically and see what can be managed conservatively. Obviously, most of us, if we had any problems, we don't want to go surgery. That is for sure. And no one will be the first one to get surgery done for ACL. No, most of us will not do. So same thing applies for each and every patient. Give them an option of rehab. Here also same progressive rehab, strengthening, and will improve their condition. And if it, but again, Western articles I was going through the review. They have reviewed the meta-analysis done, and for young athletes, rehab doesn't work well. They undergo surgery. That is what the consensus was. So injections again, it also helps local anesthesia injections into the joint if you are doing an USG guided injection into the joint and assess and see whether they have the impingement signs disappearing after local anesthesia injections. If it disappears, yes. If it disappears, yes, there is an organic lesion happening and that might be one of the cause. If it doesn't, then obviously you have to think of some other cause as your diagnosis. Viscose supplements have also shown in the literature that helps to in the very, very, very early stages of impingement. Steroids again, it's an age-old procedure. You can still try, no harm in trying steroids. So coming to operative, there are 3 methods of operating here. Arthroscopic, again, it's an advanced or long learning curve and very limited. Even in arthroscopy, it's a limited things which we can do. Open is safe surgical dislocation. Dr. Srikanth will be going through those things. And mini open is one which is done when you can do a very little safe surgical dislocation, it's not needed. So in arthroscopy, it contains of 2 components, basically a central compartment which consists of anything inside the labrum, inside into the hip joint, medial to labrum, and peripheral compartment which is lateral to labrum. So most of the cam lesions are the peripheral compartment. You can shave it if it is anteriorly. Again, if the cam lesion is something posterior, which is not common, but it can exist, your arthroscopy may not be able to help you out. So procedure which can be done under FAI, labral debridement. Debridement is also shown to improve the pain. Labral repair, cartilage procedures if they are in the periphery of your acetabulum or you are on the femoral head. Then cam lesion shaving. Again, advanced surgeons are also able to complete the pincer, which if it is anterolateral pincer impingement, they have also done a labral detachment, shaving the roof of acetabulum, attaching the labrum again. So that has also been described in the literature. So coming to arthroscopy, these are the internet images. Sorry for that, because I have not done hip impingement treatment surgically as of now, only managed conservatively. So sometimes when you have a labral debridement, most of the labrum is good, some fibers are detached, you can just shave them off. And you will have early cartilage changes which can also be done. So labral repair, this is the detached labrum, it can be attached back with 2-3 anchors. Again, this is how the arthroscopy anterolateral portal, you are looking from the anterior and anterolateral portal, your shaver can come and shave the cam lesion of the head here. So limitations of arthroscopy again are demanding procedure, long operation time, even 3 hours sometimes it takes, and learning curve is very immense. After you even start doing other shoulders, elbow and ankle scopy also, it takes a long time. Trouble in traction again, because you also have to be worried about the pudendal nerve palsy. Obese people reaching the hip becomes very difficult. So arthroscopy again versus open, it shows that it both are. If arthroscopy cannot handle the procedures, then open is much better. And as I mentioned, surgical dislocation gives you a complete visualization of both acetabular as well as the femoral head component, and you can manage your procedures easily. So contraindications which are relative for safe surgical dislocation, I think Dr. Srikanth also will cover afterwards. Basically, extensive arthritic changes, or if you have a significant protrusio or dysplasia, you cannot do a safe surgical dislocation. So I'll run, Srikanth will be going through that side. What you can do on acetabular side, basically you can check for the labrum, you can check for the any cartilage procedures into the acetabulum which are there. You can do some cartilage procedures, labral debridement, labral repairs, and definitely the pincer arrangements also can be made. But this also needs your preoperative planning very importantly, because after taking it off, you are not dissecting so much that you will know, okay, which side is more and all. So if it is superior to labrum, you can easily shave it off without touching the labrum. But if it is at the edge of the acetabular labrum, then you will have to take out the labrum, shave it off, and then put the labrum back. So the amount of rim to be resected depends upon the crossover sign, and all this needs a proper preoperative planning. Femoral side, again, yes, you are basically trying to see the femoral head sphericity with the templates which are available. And the normal cartilage will be very whitish in color. The extra grown or the cam lesion cartilage will usually be looking as like a slightly pinkish. And that is the area where you have to demarcate. So in this picture you can see that this is a normal cartilage which is usually well covered under the acetabulum. This part is the one which is slightly in off color and needs to be debrided. Again, precautions, again, when you are debriding this, if you are doing it too excessively, especially arthroscopically, lands up in the neck fracture. And if you don't take it off completely, yes, may not relieve the patient's symptoms. So coming back to labral reconstruction, which is getting more popular again in the Western world. So they use a facial lata graft, roll it and make it into prepare it like a tendon, and use labral, repair techniques like how we use for shoulder and all with an anchors. And that also is being done, nowadays. So coming to mini arthrotomy, which I was discussing, mini open is a less invasive technique. Basically, when you do a CT and MRI, find out that it is anterolateral, only a small cam lesion or a anterolateral pincer lesion. You can go ahead with the Smith-Peterson approach the femoral head, do those under the image guidance, yes, because it needs imaging. You are not visualizing the entire femoral head and the acetabulum. So image guidance is necessary. You can open and do the necessary work, and it doesn't need any dislocation here. So it is safe in that scenario, but you cannot do it for a posterior-inferior impingement or any coxa profunda which you cannot see completely. So post-operative management, again, will be toe touch weight bearing gait for another 6 weeks, which is minimum. So strengthening of isometric hip muscles, as I was mentioning, if you don't do any exercises and if you move it too much, you are scared whether you will fracture that or you will cause more harm by the already shaved part. So at least start strengthening the muscles of the hip initially. This is advocated for most, even hip arthroplasty. When you are trying to avoid some motions, you have to strengthen those muscles. And again, here, depending upon which type of cam lesion you had, where it was located, you avoid impinging that to the labrum. And if you have done a labral repair or a pincer, then again, avoid any terminal ranges. Try to keep the ranges in the mid-range so that the labrum doesn't get impinged. So CPM again with limit 70 degrees is done. Again, radiological healing, if you are seeing any osteotomy or anything, you can start weight bearing. So summary, coming again, treatment always first is non-operative, which has worked in some very few cases. I have treated clinically and diagnosed as FAI, but they have improved with rehab itself. Injections, as yes, injection helps in decision making. And the consensus of the world in the review literature is there is no role of any prophylactic surgery. If you find a large cam lesion or a large pincer or a retroversion, patient is asymptomatic, you have taken the X-ray for something else, don't advocate any surgery or don't scare them that they might have a further FAI. So there is no role of any prophylactic surgery. And take consent for both scoping and open when you are operating, because you may not be able to complete it in scoping. And counsel the patient well for a longer term rehab. It's a loading joint, as we have mentioned yesterday in biomechanics and anatomy. It's not a joint which can withstand small forces. Whenever you put it to use, a lot of forces undergo. So going back to sports will at least take 9 months to 1 year. So if they are ready for that, you have to counsel them. Or else, again, as Dr. Magu sir showed yesterday, one small incident, trivial incident, they might have a fracture. So those things are very important. Thank you.
There's some compartmental syndrome also with arthroscopy. More fluid goes and such is the fundamental surgery.
Yes, sir, it can happen because you don't put cannulas in. You put some cannulas, but you don't have that like shoulder. You don't have the plastic cannulas for hip. So if you have done opened one capsulotomy to operate and then start placing the other fluid will leak out into the surrounding tissues. But that starts compressing, but it's a large area in the hip. But the only problem in hip is you take long time to operate. That can happen. So the moment there is an extravasation into the soft tissues, it can start compressing the capsule and your visibility decreases.
One basic question.
Sir.
Your AP view,
Sir.
and all your digital X-rays.
Yes, sir.
How do you do the measurement? Because most of the people don't have that calibration ball and all is not available.
Sir.
So what do you do? You said 2 centimeters from that and all.
Correct, sir.
Now most 99% of X-rays are digital.
Correct, sir. If you have a film, it's very difficult to measure, sir. I think most of the X-ray films, when they are printed, they give a scale on the side, which is marking. It will be a tedious process, but we can do, I believe. Because whenever I have seen a digitally printed X-ray, they give a small scale, just some small.
Lot of things.
They don't do, sir. Then it becomes very difficult.
They are not giving, but the book says
Yes.
you put a calibration ball.
Yes,
and
yes.
measure, but,
No, sir, when it is being done, you have to do it, but no one does at the calibration ball initially.
Because the first thing to pick up FAI is a APU you start and the very process of doing that is little
I
flawed.
have not been. Now I don't know, sir, but yeah, that's true, sir. I agree.
But as a personal opinion, I think as people are doing more hip arthroscopies, they are picking up more FAIs.
That is always there.
How
Sir.
much
When you are, yeah, indications are always there.
Still the subject is evolving.
Yes,
One of
sir.
the indications, if everybody doesn't have an arthroscope and everybody is not familiar of doing a good chilectomy when there is a bump. When do you suggest a valgus osteotomy? Let the painful area move away from that thing which is painful.
Correct, sir. But we have to consider the other options also. Like if once the conservative fails, and if you are not comfortable, as you said, to do a safe surgical dislocation, if you are not confident of doing it, if you don't find any other options, and that is the one which is clinically definitely causing an impingement, then you can obviously people if you are like persons like you who are trained in osteotomies, we can go ahead and do that. I believe, sir.
I have to do that.
That's what, sir. That is what I was telling. So, I mean, if you are, see, obviously, sir, I mean, there are many indications will come in future also, but what you are trained to do better, you should be doing better. I would recommend that because
I see cases where infection has healed. Say a patient was ectopic hip, it heals, and now the patient has impingement. So I have been doing well. I mean, can I show some cases when I find a time? Please give me some time. I like to present few cases where there is impingement, and I have done a valgus osteotomy, and it is
disappeared.
Yes. 10 years, 15 years have passed. The patients are doing well.
Similar analogy, as I said, a microtrauma can take off the lesion.
Yes, sir. Same thing,
Because
sir.
of microtrauma, naturally the lesion. Correct?
Yours will be less riskier for a patient.
That's right.
It's much less riskier. Only thing in his biomechanics a little might change, but it's well acceptable in Indian scenario. If he's not an athlete, yes, definitely, sir.
Better to combine only valgus osteotomy would be difficult, sir. You may have to combine with flexion, rotation.
With rotation, yes.
rotation.
I will show you a case. I love to show you a case. Please bear with me. I will show you one case.
Definitely. We will answer. Please, sir.
You said you always opt conservative treatment whenever you see any image finding.
Yes, sir.
But do you think that that image finding will remodel itself?
No, never, sir. It may not, sir. It may not. But actually, patient symptoms get reduced. I mean, it all depends on what kind of patients you have.
Mostly it's a symptomatic disease.
Yes, sir. Yes.
Sign, not what we are looking at. Because pain is always personal. It cannot be, only vascular can evaluate it properly and about it. The rest of it is not personal. So most of Western patients may not tolerate pain. Most of our patients tolerate pain very well.
So you saw yesterday, sir, like big patient squatting, yeah.
We shave a hip and
There is a difference. There is a vast difference between the X-rays and the clinical. The patient sits nicely even though the head is big.
And I mean, many of my patients were like cam lesions on both hips, but present only symptoms on one side.
Exactly. So treat their symptoms rather than the X-rays.
And the X-rays.
That's the correct. Srikanth, can you go ahead?
Sir, last question. Difference between frog leg lateral view and modified turn view. Apart, can you go again?
Frog leg, you will have rotational component. You hold it and turn it, so there is a rotation of the hip happening there. In the turn view, you don't rotate it. You flex it and abduct it. This is how it is taken.
So we'll move ahead with the safe surgical dislocation.
Good morning, everybody. Surgical dislocation of hip. I'll keep my presentation along with case examples. This 14-year-old boy, he came with chronic stable slipped capital femoral epiphysis. It was chronic, he was able to walk. By stable we mean, by stable we mean he was able to walk. By chronic we mean it was more than 3 to 4 weeks, 3 weeks by definition. So all I could do was in situ pinning and remove the bump. But definitely you can see the amount of bump there that would have already caused some labral damage as we have seen in the previous lecture. And if and he was walking, and I'm sorry I don't have the immediate pre-op clinical image. Needless to say, the X-ray will say that patient was completely having the limb in external rotation and he was walking with a limp. Absolutely no chance of flexion internal rotation. Your Drahman sign was positive. So luckily, Dr. Prasad Garuneni, he obliged to operate this case at NIMS. When he did safe surgical dislocation and capital realignment and restored the anatomy completely, and you can see a 3-year follow-up now. Thanks to him, that is when I first learned this technique of safe surgical dislocation. Following which we had a series of around 5 cases.
Srikanth,
Sir,
do we see some avian changes in the hip?
in
3-year
follow-up. 3-year follow-up, sir. I'm not sure, sir, but clinically he's absolutely, I don't think, yeah.
Growth plate also closed.
Growth plate has closed.
Yeah, he's already 14. Yeah, growth plate will be closed. That is what we do in capital realignment or in situ pinning also. In fact, in capital realignment, we scoop the epiphysis and see that the metaphysis and the epiphysis unite. That is what we want. Absolutely no role of presence of growth plate. The growth plate fusion is what we desire, whether it is in situ or capital realignment. And of course, it happens around the age of 14 or 15, and growth, that doesn't matter at that age. Yeah, his walking video, I'm not able to play. He is walking perfectly with normal alignment. So, coming to the surgical technique per se, this is described with another case example which I have done very recently. We means I took the help of Dr. Vidyasagar Chandan Kere, who is my close friend. I had helped him in 3 or 4 cases. He came to my cases. Because this is not a simple surgery. When it is done in slipped capital femoral epiphysis, we'll see what the difference is in slippery actually is and what routine safe surgical dislocation is. First few steps are standard for every case. This is the landmark article which was published way back in 2001. Actually, when you look into internet, it is one of the most viewed articles in JBJS itself. Most downloaded article, most cited, around 450 citations are there. Where they have done around 200 odd cases, dislocated hip, and with no single case of avian. That means there is a way to dislocate the head and see completely the femoral head without jeopardizing its blood supply. This was the case example that I was telling. A recent case, chronic stable slipped capital femoral epiphysis. We gave the option for the patient for both in situ pinning and simple bumpectomy from anterior approach and modified safe surgical dislocation approach. We explained him very well the risks of avian. Having seen another follow-up with good outcome, the patient, the parents chose to go for capital realignment. And why? Before we go to the surgical technique per se, we have to realize the rationale behind this surgery. The most important thing is the blood supply to the femoral head comes from the posterior aspect. Whenever we do a hemiarthroplasty or a THR, we cut the external rotators at the insertion without any concern, because we don't need to concern. And even I have the habit of suturing the external rotators to the trochanter by putting drill holes. But this can't be done for every case. If suppose we are operating a femoral head fracture, or let us say a acetabular fracture, we all know Cochran-Langenberg approach, where we cut the rotators slide 1 or 2 centimeters away from the insertion. The reason being, the blood supply is middle circumflex femoral artery, which is the main blood supply, is very close to the posterior edge of the trochanter. So we take that care when we are operating acetabular fractures. But is there any way to completely avoid this approach and go dislocate the hip without going by posterior approach? Yes. Patient will be kept in lateral position. Here, in Cochran-Langenberg, we curve the incision posteriorly, posterolaterally. But here, in modified done or safe surgical dislocation approach, the recommendation is to go straight lateral incision. Of course, it seems you can go by Cochran-Langenberg also, where we generally split the Gmax in Cochran-Langenberg. Here, we take Gibson interval between Gmax and tensor fascia and identify all the perforators there and develop a correct plane. Almost to say it is a straight incision both superficially and in the deep level. That's the trochanteric flip. I will come mix up the slides. It's okay. This is just to highlight why how capital realignment is different from in situ pinning. In capital realignment, in acute sleep, where these posterior retinacular vessels get kinked. So the recommendation is do in situ pinning and not try to relocate it. When you try to relocate it, we can jeopardize the posterior blood supply. In a chronic sleep, sometimes it is more difficult because there will be already callus formed here. So if you try to reposition, one thing you can't. Even if you can, it is at the cost of the kinking of the posterior blood supply to the epiphysis and jeopardizing its blood supply. So only way out is to remove all this callus carefully and preserve the blood supply which is coming to the epiphysis through this posterior retinacular flap, and do a shortening of the neck and do in situ pinning. Here comes the complexity of use of safe surgical dislocation in the setting of slipped capital femoral epiphysis. But first few steps is same for any indication of SSD. These are the first few steps where a trochanteric flip osteotomy, after dividing the plane between Gmax and tensor, and after we go here, we do a trochanteric flip osteotomy, which is to see that the thickness of the trochanteric flip we make is only 1.5 centimeter, not more than that. The reason being, we want to keep the external rotators and the piriformis insertion onto the stable trochanter. I'll show it here. I'm sorry, you're not able to hear, I think, because there is a VGA cable. Some fibers are still attached with the stable part of the trochanter, proximally. That is the proximal end. There is a distal end. Vastus lateralis on one hand and gluteus medius fibers on the proximal side. There is a digastric, or we can even call it trigastric, because some fibers of gluteus minimus are also inserted here. Then next step is to, after we retract the trochanteric flip anteriorly and external rotate and remove all the muscle attachments from the capsule. There will be a lot of muscles like gluteus minimus, inocapsularis blended with the capsule. All we have to do is remove all those red muscle fibers from the white. We can use a artery, and we should see that we do not penetrate the capsule. We have to remain above the capsule and remove all and try to expose the capsule as much as possible as much as possible, as posteriorly as possible, even before doing capsulotomy. Next comes the capsulotomy. The described capsulotomy is a Z-shaped capsulotomy, or we can even do a T-shaped capsulotomy. My point here is the capsulotomy will be, the middle limb will be in the superior aspect of the neck, superior, because blood supply comes from superior proximal and posterior aspect. So this will be the middle limb, and in the inferior limb will go towards the lesser trochanter, but stop at lesser trochanter, because behind the lesser trochanter itself will have middle circumflex femoral artery, and the proximal limb is curved along the labrum. Will not injure the labrum, and curved along the acetabular margin and try to go as posterior as possible, way back till the piriformis. And this, while giving this cut, we have to ensure that we retain capsule enough to do subsequent closure. We can even put a tags to the capsule at this level before after this, so as to ensure correct approximation afterwards. After the capsulotomy, you external rotate the leg and put the leg anteriorly. We will have a sterile bag and keep it in figure of 4 position. Your assistant should hold it very well, and you can completely see the femoral head, and even if you retract, you can see the acetabulum also. Here ends the safe surgical dislocation part. After that, it depends on what your indication is. Here the indication was slipped capital epiphysis. Here we check the vascularity of the epiphysis even before trying to separate. Here if you see, even before dislocating, we put 2 wires, 2 K wires from the neck into the epiphysis, from the metaphysis into the epiphysis, or neck into the head. That is because if you try to dislocate without this step, you may cause rip off the epiphysis may remain inside the acetabulum. We don't know whether it is really stable or not. So clinical Lauder classification of stability may not correlate with radiological or intra. So we have to take all the care to in this step and check the vascularity even before. As you can see, the bump which the previous speaker has described, Dr. Akash, this is what we can do in situ pinning, but this is what is going to damage the labrum. And this is not which is allowing him to flex and internal rotate. That is what we want to get rid of. We can do it safely even at this stage by just shaving off the bump and putting the head back and closing. That's a fairly safe option. And next step is next comes the development of retinacular flaps, before which we have to do decancellation of this part. This is the epiphysis, this is the fascial line we see, and we remove all the bone here. Here I am doing with a burr, but this is the most important step. But we don't always use the burr here. On the initial few steps, we use burr. Actually, it is best to use a scoop or curate or a knife or lots of 11 number plates and remove the bone very, very carefully, meticulously, and this is the most time-taking procedure because we don't want to jeopardize the posterior retinacular blood supply. And then we give an incision onto the anterior part of the neck and raise flaps. Here you can see anteromedial flap and a posterior flap. This posterior flap, if you see, posterior flap, the femoral neck is literally skeletonized. Femoral neck is literally skeletonized with intact periosteal flap. See, if you can see, the posterior flap has external rotators still attached to it. These external rotators and the middle circumflex gives vascularity to this epiphysis. That is the technique of elevating the flap. Very meticulously, very slowly we have to elevate the flap, and that is the lateral flap, the other one is the medial flap. That is my friend and colleague Dr. Vidyasagar, both of us were doing. Yeah. Yeah. Say, then the same thing shown here after in an advanced stage. The separation, yeah. Here we are trying to separate the femoral epiphysis from the metaphysis. And carefully, because there will be callus behind the neck. So we have to do it slowly and removing all the callus. This is after separation. If you can see, this epiphysis is separated, but it derives blood supply from this flap and this flap, mostly the posterior flap. And next comes the neck preparation. Because we want to put the epiphysis back onto the neck, this doesn't happen without some shortening of the neck. Some shortening has to be done, otherwise there will be tension on the retinacular flap. But this shortening should not be too much, otherwise there will be hip instability. So we should do it slowly, checking again and again that there is no much tension on the posterior flap. You can use a nibbler, you can use a knife, it's up to you what to do. But this is the posterior aspect of the neck, I am removing the callus. And another important part is relative neck lengthening. Like Dr. Harish showed yesterday, we are relatively lengthening the neck. What we are doing is we are technically nibbling of the part of the neck which is attached to the GT. Here we have osteotomized the greater trochanter. Even then, a part of the greater trochanter is there on the stable part. That part, junction between the neck and the trochanter, that we have to nibble off, so that relatively the neck becomes longer. And this is how we have to curate the physis. Like I just told, we have to curate the physis and remove all the it's something like we do in GCT, like that we have to decancel, do decancellation, so that it can be reposed without much tension. That is at the end. After realignment and fixation, we are trying to see the blood supply. There is some decrease in blood supply, but active bleed was there. I don't know what is going to be the fate of this patient, but out of 5 cases, we had one avian, which I am going to show subsequently. And this is a recent case, and this is the post-op. Here I want to say one thing which I haven't shown. While putting this K-wire, we do a retrograde wire after capital rail. Before replacing this, we put a wire in retrograde fashion and do realignment and bring it outside from the lateral aspect of the trochanter. That's the easy way of doing rather than taking 2 millisciam shots. And usually the fixation is with one screw and one K-wire, threaded K-wire. That is most important. This wire should be threaded because we don't want it to penetrate into the joint. There is not much space. We don't have much space. Only it's like a ping pong ball, the epiphysis. Yeah. This is another example of chronic stable slipped capital femoral epiphysis. This was how he was walking. This was how the action rotation deformity, Drehman sign. This is the pre-op. This is the intra-op. Same thing. Here you can see head was bleeding well at the end of surgery. This is the post-op. That is a post-op day 2 or day 3 bone scan that we got done to confirm the head vascularity. If you can see, the neck seems to be avascular because we have stripped off all the periosteum, but epiphysis is vascular, if you can see on this bone scan. And that's the follow-up. I am not able to play the video. He is walking normally, normal gait. Another example, this unfortunately went for avian. So it is not without risk. And this is another indication of safe surgical dislocation is relative neck lengthening. This child, I can't exactly pinpoint the diagnosis, but he is having coxa vara and caput valgum here. You can see the epiphysis is in severe valgus, only the epiphysis part. So he had abductor lurch and pain. So we did relative neck lengthening. Here, in fact, if I remember, I did not dislocate the head. Only trochanteric flip, expose the neck, and do the relative neck lengthening. The nibbling of the trochanter neck junction and causing and distalizing the trochanter. Distalizing is an important step even in slip capital femoral phases also. We have to distalize the greater trochanter and put 2 screws because indirectly we are articular trochanteric distance we are increasing by doing that. Self surgical dislocation can be used also for femoral head fractures, Pipkin type fractures. We know very well we have been doing femoral head fractures. We go by posterior approach if there is posterior dislocation. But the concept that already posterior dislocation is there, why to go anterior, that concept is gone now because the posterior external rotators are usually intact. We have to try to preserve the posterior blood supply, and more importantly, if you go with posterior approach, we have to take all the care to preserve the vascularity. But in this femoral head fracture, if you go anteriorly by self-surgical dislocation approach, the most important advantage is you can put the screws from anterior to posterior to the Pipkin fragment. It is very easy. Otherwise, it will be very cumbersome to put screws. Sometimes this Pipkin fragment will have attachments. We try to preserve that attachment as much as possible. That is the post-operative X-ray of femoral head fracture done by SSD approach. Yeah. Any other indications? Yes. If you have any lesion of osteochondroma or osteoid in the anterior aspect, of course you can do a radio frequency ablation, but most of the time we try to do excision. But any curettage, we can go by self-surgical dislocation approach if the lesion is very much anterior without jeopardizing the blood supply. Another indication is acetabular fractures. We have never done in acetabular fractures. They say we can even do a posterior column plating also, but we don't have that experience. And post-Perthes or post-infective sequelae. If you remember yesterday, Dr. Harish has shown one example of post-Perthes sequelae where the head was misshapen. He did it by surgical dislocation approach and removed the bump part. Another extended indication is a femoral head reduction osteotomy. This is very complex. I can't imagine a head splitting the head into two and getting a spherical shape. I think that can be attempted by only highly experienced surgeons. With our limited experience, this is our experience of self-surgical dislocation approach. Yeah, thank you. Thank you.
Super. Well done. I think every one of us are clear about SSD. Good. Sir, you want to say something?
Very nice presentation. I have some cases if you allow.
Yeah, sure.
Maybe my diagnosis is wrong, but the way I do it, I'm sure.
So for the last case which you did, can we do epiphysiodesis of the trochanter, just like do your Perthes, and in long term it will increase?
And allow the femoral epiphysis to grow and stop the bleeding. But the point is there is limited growth in the proximal femur, and that to rely only on the capital femoral growth and stopping GT. That is a safe option. Just put a screw into the GT. That is fine. But here, because we can do a safe, here we do not dislocate. It is not so difficult as in a slip. Just do a trochanteric flip carefully and shave off the neck at the head neck junction and distalize the trochanter. Okay. Here, most important advantage is if you distalize the trochanter, you are relatively improving his abductor lurch. I need to have the follow-up.
Sir, one more question. So all the
at this age, younger children, is there any contribution from the ligamentum teres?
Hardly has any.
At this point, it's not.
In adults, it doesn't have.
No, but we are talking about children now.
Yeah, but 14, 15.
Yeah,
Head
has come out and so.
That too ligamentum teres. Technically, GANS has done in adults.
Yeah, GANS has done.
So ligamentum teres, according to literature, hardly contributes.
No, but children I'm asking.
But we have experience of very small children.
because you got very good bleeding when you put the KY in the
Sometimes
head.
we get, sometimes we get.
Yeah, sometimes you don't get, even in avians. Surprisingly, you get bleeding from the avascular segment, not from the.
I want to ask from your experience. You are dislocating areas.
Yeah.
Where do you get bleeding? Where do you don't get bleeding? Does it correlate really with MRI?
That's what I'm saying. Not with MRI. You say you do the Kerbal and map out which is the area which is normal femoral head. So sometimes it's okay. Sometimes you put the KY, you get bleeding. In about 2/3 of the cases you get bleeding, but some of the cases you don't get bleeding, and you get a lot of serous fluid because probably there is a lot of intraosseous pressure. So now what we started doing is when we are doing FR was we put multiple 1.4 or 1.2 mm KY holes into the femoral head so that
Necrotic fragment or
in the necrotic and even the normal.
necrotic doesn't it allow more collapse?
No, sir, you're going to put very small KYs, no? It's not allowing any collapse. And the thing is, once you're doing FRO, you are rotating the necrotic area out of the weight bearing.
Anyway, it is coming out of the.
And the other thing is, the lot of articles have come, is you don't have to rotate all the necrotic area outside. There is what is called the post-op intact area. So it is said that literature about 35% of healthy bone is enough to preserve the femoral head. So you don't have to go beyond 90 or 100 degrees because the more you rotate, the more you are stretching the vessels one way or the other.
The same thing happens here. The more, if you don't rearrange the epiphysis normally and do some intorsion, blood supply is not. And Dr. Prasad Gaurani, experienced people like him, he says he has taken the patient back to OT and did rearrange.
Rotating back.
Very complex.
Because you don't have as much numbers as severe cavalry, about 20, 25 together. So, but these things, time only will tell. How
Very novel approach.
it is from the books now, we didn't do anything. We are kind of reinventing the wheel. I think they should try. This was a new idea to me. I will try bone scan in our patients after FRO, see how it goes. Thank you.
My videos are not working. But one video is working. See this girl, 20 years, female. Why not fall? Yeah, my senses are okay. Thank you very much. So she had infection. So she had hinge abduction, just 10 degree. Fine here, just 10 degree. Fixed internal rotation, 25 degree. Dr. Shrikant and all the stalwarts. My slide, please. Your attention is invited. Santosh, sir. Very Santosh. Oh, he is missing. He is very bad.
There's got to watch out.
Okay. You are asking me a question also. You people are asking me this. Not just hinge abduction. You see here, fixed internal rotation 25 degree. So, symptom, fixed internal rotation. Fixed internal rotation, I am talking, sir. It is fixed. Fixed. Okay? She suffered from tuberculosis. This is 93, 94, 95. Age that time, I operated her in. She was child when she was child. It's not 20. It is tuberculosis, boundary must have been almost. Could be not Perthes. In Perthes, you will not have fixed internal rotation. Yeah. Internal rotation is limited. Okay? So, this heel, and she's sitting like this. she is a student of engineering now. When she came to me, and you can understand how she squats. She just cannot sit external rotation, cross legs, and how she is performing her morning day-to-day activities, difficult to presume. Now she is adult. Yeah, this is there. See how she is walking. Yeah, इसको चलाओ एक तो. इसके अंदर तो है. इसके अंदर तो है तो चलेगा. You see this? Okay, show the slides, please. We will. The movements will show in the end. So this is reduced joint space, and this is the osteophyte which is formed here, and this much is abduction. Does it come under the definition?
I mean, there is a joint space narrowing, we could call it as arthritis.
Arthritic changes have occurred secondary to the disease. That was 10 years back. Now she is adult, fully grown. So does it cover? Does FAI cover this fixed abduction? No. This is head extrusion, I say. This is going in abduction. The adduction is far more than middle third of the opposite thigh. Far more. Abduction. Adduction. You can take it like this. Abduction is just 10 degree and there is internal rotation. Why is not FAI? When there is a hinge abduction, femoroacetabular, whether there is a cartilage, I don't know what is there. Let us see the slides. I am just learning from you. And how I work.
It's very femoroacetabular obstruction.
It is femoroacetabular obstruction. Okay, you say arthritis.
No, sir. I mean, the impingement in hip is different from the femoroacetabular impingement.
But infection is one cause for that.
Yes.
I will show you other case also.
Yes, no.
You see here this. I'm not joking. It is abduction here. It is hinge now.
No, we agree with you, sir. I feel it is an abduction. It's an impingement only.
Okay.
But it's probably more advanced stage. That's what we would. I mean, I would feel that.
Okay, sir. Okay. CT done. Remodeling defect, and you find here the lesion, healed infection also. Here you see this very much thickened, broad. And arthritic changes, I agree with you. And the head is also deformed. Head is not normal. So in your definition, if acetabulum is deformed or head is deformed, it is cam-like. So head is deformed, it is not spherical, you are saying? It's not spherical. And acetabulum is also involved. Maybe your labor is involved or not. I don't know. I have not done arthroscopy, no MRI. You may be able to diagnose it. You see? I'm just learning here. Please don't mind. This head is not spherical. And head is diseased here. The acetabulum is also diseased here. And there is a hinge abduction. Okay. This head is very nice. You see? This is spherical. This is not spherical. Okay. And why it is not hinged here? It is hinged. See this section. Because the shape is not rounded, so it is hinged. Okay. It is hinged. You may be better reading the CT. So maybe you read better MRI than me. You find something here? Or in other sections? I will give you this piece. So see, this shortening and there is internal rotation, you see. And this is normal side. Yes, gross wasting, lateral internal rotation is shortening. And this is the, at the time of surgery in OT itself. And see here, this internal rotation, shortening. And I have just given this in CN as I showed you yesterday. Okay, and done the osteotomy and took out this wedge. too hot an atmosphere. Academics. मैं टॉर्च दिखा दो शायद चल पड़े. It never happened yesterday. I took out this bed. Can I have your attention on my left side, please? Friends, I did the valgus of Jorby and corrected the derotation, rotation deformity and caused derotation, completed the neutral position, and lateralized the fragment to lengthen the limb. While she was walking with a intelligent gait, internal rotation of the knee with heel of the ground, internal rotation and adduction. Very awkward gait, intelligent gait. In various indications, osteoporosis is a very good indication. So those days I classified my cases as per Singh's index. You must have seen grade 3, and the DEXA was not there those days. So I presented that paper in IACON 1992 at Lucknow. That was my first national presentation also. And that article and my references cited. I have 14 articles published in international journals. I'm the only one from the world. Others have published 1 or 2 maximum, all stalwarts, but I have 14. So that case is published in Injury. But I have the follow-up of now 15 years after that the patient died. Okay? See, this is the wedge. This is the wedge. And you see here, this is opened here. I'm just closing. And this is my test. That if you are able to make a position of 4 peroperatively at the end of your surgery, so this patient will be able to squat cross leg. If not, then again I will correct the rotation or something. There is no mathematical calculation, it is just clinical operative calculation.
So you put all these screws, you do this test?
Yes. 1 screw. After 1 screw or 2 screws, I do this test. I test the flexion, rotations, everything. Now you see, this is the guide wire, and this is huge osteophyte, I should say. And this is the maximum abduction which you do, and that is the chisel you have seen, and that is the wedge. My student, he measured it, I just saw. So this is the wedge which is excised. This is the wedge which is excised, and this B by. Now I corrected the rotation. And after that I lateralized it. You see this is lateralized. So this is the relative lengthening of the neck. See here. And the way I place the wedge of bone excised from here at the elbow, same I did there also. Okay? And see here. Osteoperatively, you see, now there is external rotation. There is external rotation. Initially, I showed you internal rotation. And this is X-ray post-operative. See, so much of lateralization is done. Literature say do at the most 1/4 of the diameter of the osteotomy site. I have done 3/4. And this heals. This all heals. It heals. Yeah. I say the mesenchymal cells are and osteoporogenerator cells are very active.
Trochanteric is published as trochanteric bone marrow is much active than the iliac crest bone marrow. That's one article I had.
But this is osteotomy only. I have not taken any graft. This graft is because of the surgery itself. So I have made use of that. I never throw that. At times I throw also because I don't have anything now. See this beautiful healing going on. And but the joint space, I don't think it widens, or it is slightly widened, as Bombley says, because other article cartilage has come under the line of weight bearing or making congruency. And you see the abduction now. You in abduction, you see, in abduction you gain, in valgus osteotomy, the abduction range is increased. I said, what is happening? That the case you were talking about, that patient with osteoporosis, I said, yaar, iski abduction to sari 40 degree se upar hui hai, kya hua? Because this is done at the cost of adduction. Adduction, we don't use movement very frequently. It is abduction and external rotation which we use. Okay? So, now see this. Limb length is almost equalized. I will show you more slides also. And this is going in internal rotation. It is neutral rotation now. And see, this is initial. And this is after surgery. This is after surgery. And you see here, the gain of abduction is, flexion is about 20 degree, and she can sit cross-legged. It is made, this is not limited. This is made from the video. This picture is taken from the video when she is walking and sitting. I'll show you that also. And you see, it is equalization. There is no equinus. See here. Now this is at 2011. Prasad, when he sees my cases, your friend, he goes mad. And he's tried so many times having confrontation with me. Every time I sorry to say defeated him, and then he starts crying. He thinks he's very big boss. He's my friend otherwise. He gives me the ring. And recently he asked me, please give me your work. I want to publish a book. So one of his friend and my friend say, he will cheat you. I'm very open, very blunt when I'm truthful. And people want to grab your work. Same is happening in IUA. All the honest people are sidelined. They will make you defeat. And they will bring only corrupt, unacademic people.
Because they also know who.
Yeah, this is what is happening. Kaurav Pandavas, okay, don't mind. So, I showed my case to Prasad.
We keep following the discussion.
You must keep on. So I left his group. He said, don't leave me. You are not worthy of that. I should keep in me. See, 86 weeks follow-up. Nobody can challenge me. I Santos ki blasted in Chennai. Why limb is there? There is no limb. You are biased against osteotomy. That's why you rejected my paper. But same was accepted by injury. Really, I made it. It is my country's question. It is the respect of my people of the country. That they are doing genuine work, and you harass them and humiliate them and purposely reject their papers. Now they are not rejecting, you see. There is change in attitude. This is 160 weeks, you see. This is 16. See how beautifully she is sitting. 325 weeks. Nobody can challenge you. No international person can challenge you. I talk to them with an authority that I am from India. And I'm proud of my country. And the material of the kind of materials we have, you never had, you will never have. They will have more money only. That again they will be short at the bride of. See,
even if you put in group also, any younger surgeons you put, most of them will
So what is that? I'm still surprised because wellness osteotomy create more stress by mechanically.
Read Bombelli. He says capsule gets thickened. Yeah, in series also what Professor Tulli had done. See, when I corrected his case from a deformity, internal to external, I made capsule again as a roof bearing because that was very strong. There was the telescopic test was negative, and he was walking full weight bearing on the capsule. So there is sport in your favor in literature. Bombelli is one sport. He's also done thousands of cases. Only thing is that we have sold ourselves in the hands of orthoplasty people. You can have a workshop of orthoplasty in any village because they are sponsoring. They will never sponsor osteotomy. And some research will come when we will be able to regenerate and transplant cartilage. These people will be beggar, you see, I tell you. This is 10 years. Prasad said, okay, hats off to you, Dr. Modi. Same joint. This graft is healed, this osteotomy. See the wonderful healing. Okay?
It doesn't look more well, that also reflected actually.
Yeah. It is there definitely. You see, this is the roof. Now this is working as a roof for weight bearing. And because of the valvization, the hinge abduction is now corrected. And you see this. Now this is she was, this is she now, and she has a child. She was unmarried that time. Before surgery.
She's bending her head in shame. You see that?
No, she is very good girl. See, when I put up my case on the internet, she wrote a statement that this is published at her home. This is published with my permission, and I'm proud to be treated by Dr. Madhu. It is on internet. People tell me, I don't know how to see that. यार वो वीडियो चलाना प्लीज अलग से था, एक मैं आपको बोला था ना जिसमें तीनों हैं. जस्ट श्रीकांत एक मिनट यहाँ से प्लीज अलग से दिया था सुन के ये दे वो मेरा See this. She is before surgery in my OT at Rohtak. Internal rotation you see here, and this is how she is sitting. See, the heel is up facing the roof, and now she is see this awkward movement. This is how she is sitting. And you see how she is standing and how she is walking, and this is after surgery. Thank you very much. So your lecture now?
Now we are ready to discuss.
Okay. One more case?
Super. I think all of us should nominate Mr. Madhu for Dharma.
I want to show my longest follow with your permission.
500 please.
Or longest follow. One case.
Yeah, sure, sir.
One more thing, sir. One more thing is, we should also remember even the X-ray looks arthritic. Osteotomy still has a role provided in the indication.
And you should fight for your belief.
Yes, sir. That is
Like him. Not back off.
The only case you will not see in literature. Next, please. See, this is fracture neck of femur.
Lights up.
It's not working. चल रही है? अच्छा, okay. Next. Yeah, this was operated by my boss, either Professor Manuel Chadda in 1973. McMillan's. So then he had fracture of the other side in 1992. So I did the valgus story. I was very much scared. Yeah. On one side is McMillan's, on the other side. See the lateral 10 weeks and 16 weeks. Okay, next please. So 35 weeks, 91 weeks. This was also a case which was rejected by Swan's procedure. So injury people immediately by returns post wrote me. Those days it was not digital. Please send your paper again, make the following corrections. So they called why osteoporosis at the age of 50. So Professor Sankaran had given me a book. He had written a book where he had mentioned that in Indian patients osteoporosis seen right at the age of 50 onwards. So I sent him that reference of Professor Sankaran, and he was an international person. Paper immediately accepted. Next please. 540 weeks up to this week time, This is with this follow-up, it is published in injury as one of the cases, valgus osteotomy, modified valgus osteotomy in patient with osteoporosis. And you see here, you ask me a question. So you see that there is balancing of the body liver arm, muscular liver arm. And here no limb, interestingly. Next again. Yeah, only thing is, on the side of McMahon osteotomy, the external rotation is limited. That is because those days there was no proper implant to fix the osteotomy, and the valgus osteotomy you can use various implants. You see full flexion. And this fellow, can you show one video? जो सबसे पहला 2006 का no okay yes maybe that last one
2012 sir.
हाँ इससे पहले भी था आप 2012 का दिखा देता हूँ. So you see, this is again the corridor of my paraplegic ward at Orthopaedic. See, there is no limb. He is about 80-85. Okay? I think he is. See, yes. He is so grateful to me. He says, Dr. Mabu, whenever you call me follow-up, I'll come. मैं मर रहा हूँ तो भी आऊँगा. So the last follow-up, I said, yeah, this fellow might not have died. How to locate him? बस करो. She is sweating, full sweating. He is also about 65. Okay? Then I located him, I went to his house, his shop, everywhere, and ultimately I came to know he's alive. And he's in Noida. So I telephoned him to Noida, he was with his son. Everybody knew me, there is one Dr. Mabu who operated my father. So he said, sir, I will positively come to Rohtak, don't worry, I will bring my father. And he brought him here, you see. He underwent cardiac arrest. Then he revived. And tracheostomy was done, he was put on ventilator. He was for 4 months on ventilator. And his bill was 86 lakh rupees with sign of tracheostomy. I said, yeah, how did you pay the bill? He said, Tata paid the bill. From that day onward, I tell you, the respect for Tata increased my heart many-fold. He says, all employees, including their parents, they get the refund of their money in case of illness for all their members. So that is what Tata is doing to this country. You see, no other insurance company, no other private people are doing. He is a person for Bharat Ratna, I tell you, not others. He is the one, he should be, first of all, be given the Bharat Ratna award, honored with. And that honor is also less than that. Okay, please, next. So this is after 2012, I kept on searching him. You see, next please.
Then what is the follow-up with the acquired osteotomy?
It is still going on.
Your follow-up is 540. Maybe that
No, this is published. That was. I've shown the paper. Next, please. Next. Next. You see, this is the paper which is published. Injury. Okay, 2005. 110 to 122. Okay, next, please. Next. This is, you see, 73. This is 1992. Excellent congruity. You see, excellent congruity. Only radiological increased stresses, not working clinically. You cannot have any case of bilateral THR in one patient with such a long follow-up of 50 years. I am going to show you 50 years follow-up.
This is 2022.
अभी और भी है अभी कहानी और भी है picture is lucky and I see the letter. See, it's beautiful. More abduction on the side of McMahon osteotomy. Next, please. This is before my clinic 220. Can you show this video? ये मेरी मस्जिद में था. See, I want to take a picture of heat across me, but I just could not. Next slide, please. Last slide, last but one. Open the, yeah. And where we were, yes, and yes, next, yes, next, 22, this paper, and the X-ray of 2020, show X-ray of 2020. This is my boss. So we both are same from behind. And now third is our friend. I will include Basuki. 49 is follow. Slide of 49 years. एक दिखाना ना पिछली स्लाइड यार, इससे पहले की स्लाइड दिखा दे यार. X-ray. I think I have.
This is 2022.
No, this is no. I think this is in my. I have forgot to make a. I have forgot to make a slide.
This is the recent, 26 to 2022.
No. It is not. It is not. Oh, okay, yes, it is the same. But I have not mentioned. I have wrongly written this. This is 2020. You can show the 12, the previous one. Show the previous one. इससे पहले हाँ अब इसके बाद की दिखाओ ना. इससे पहले भी इस बाद की भी. So that is done by me wrongly. Wrongly that is done. This is 2020. Excellent. Super.
Sir, what was the time between the initial fracture and the valgus osteotomy, sir?
Must be very long back.
Not
more than about 2 weeks between osteotomy and the fracture, because we belong to Rohtak. 2 weeks. Only delay in PSCA and all. But
Super, sir. Our heads may fail, heads may become bald. Femoral head is not becoming bald.
yes.
Thank you, sir. Excellent. Now we will have a tea break.
This is the joint in view. The joint is congruous and head is spherical. And this is the area seems recent is appearing. Maybe it is a great.
We are not able to see that much so clearly here.
So clearly.
Yeah, but it's good you can see.
And there is no stress fracture. It is osteoporotic. But we should not comment about this employment of war. Cars is okay, no break. So can we have back to you now?
So what is the plan, sir, now?
This plan of the lateral view. So it is the anterior part which is involved. You see here. Roof as well as the anterior part is involved. So I will insert a K wire into the lesion.
Okay, sir.
Into this lesion, both confirm the position of K wire that it is into the lesion in AP as well as in lateral view, and will take first graph from the trochanteric area as well as the necrotic part.
Fine, sir.
So maybe I am successful in that, because last 2 cases I did not find graft because of the osteoporosis in these patients. So the healthy graft will be from the trochanteric area, from this area. The healthy graft will be from this area, and that graft which I showed you yesterday will be from this. Will be from this.
Can you show it in this view, sir? We can see now.
Let's do
Sir.
Can you see my finger?
Yes, sir.
This is the area of necrotic.
Fine, sir. That looks anterior.
Yeah, that's anterior. Anterior is very right
Anterior,
side.
yes.
Posterior is good. And anterior is also the roof part. So most commonly the anterior and the roof part is involved. Roof part and anterior is involved in alien. So this is a classical alien. And the good thing is that the head is spherical, not collapsed. So we will debride this necrotic bone and with the tools which we have, and after that we will put the graft, the healthy bone taken from the trochanter, we will put it into the necrotic area which is debrided, and the dead bone towards the trochanter. So we may also take some graft, it is less from the trochanteric area, and that is what I do, and we will close the procedure. Anything you want to ask me? Any questions?
Okay. If they are asking any osteophytes are there in the vestibular Right.
There is no osteophyte here. I don't find any appreciable osteophyte. What is the age of this patient? She is just 30 odd. Just 30.
Can we have the AP view, sir, for one? That's here.
Yeah, he will show you, doctor.
So Professor Margo is going to scrub in.
So they feel that it's an osteophyte.
Non-osteophyte, yeah. It's non-osteophyte.
Okay, sir.
But what is this exact location? Is it inferiorly, superiorly, posteriorly? We could not find in lateral view. Okay. In lateral view also it should be better. This is not better. So there is no such osteophyte here.
Okay. One significant one.
Looking significant in the view.
Okay, Professor Margo is going to scrub in.
Sir, can the MRI be zoomed and shown? Is it possible?
Please show them.
MRI.
Sir, so ask the cameraman to focus on.
Can you see now?
Yes, sir, but it's a whole film which we cannot appreciate much.
Zoom.
Yeah.
Zoom in. Zoom data.
Yes, sir, that should be okay.
Can you see now?
Yes, sir.
MRI shows. You know we are doing it at the right side.
Can he come down and lower down, please? Yes, this should be fine, sir.
Yeah.
There's enough. Let it go, sir. The head is not safe.
Now I am able to see MRI properly?
Yes, this is good. So we are planning to operate both hips or only one?
No, we are planning to operate on the right side.
Okay.
Not on the left side. Left side is a little bit advanced. Going to stage 3.
Okay.
Yeah, there is no harm in trying body compression.
Yes.
But the results may not be such good.
Okay.
The plan is we have to do a body compression and then later we are going to put the patient on bisphosphonates and non-regulated like that.
Okay, sir.
Okay.
Sir. Thank you.
So while Professor Margo is scrubbing in, I am going to introduce the anesthesia team to you.
Yes, please, sir. Audible, sir. Please. No.
Final anesthesia, for 48 days.
We couldn't hear your name, sir. Your name? Okay, sir. Thank you.
This is Mr. Dugaba, anesthesia technician. Clear?
Good morning, sir.
Okay.
Good morning, sir. Yeah, good morning. My name is Durga. This is the technician, sir. Very good. All the best for you.
And this is our OT staff.
Good morning, sir. Supporting staff, sir.
Good morning from all of us here to you.
That's yesterday he spoke to you. That's our imaging technician.
Okay, sir. Yes. Yeah. Hi from all of us here.
Here, the other team members, Dr. Varapasad Reddy,
Okay.
super orthopedic surgeon.
Yes.
And this is Anjali Devi.
Good morning.
Okay. Narendra Reddy, Dr. Narendra Reddy, another orthopedic surgeon here. And myself, Dr. Vasan. So this is the situation now.
You don't do it on bracket table, sir?
No, we are doing an electroplating table. But Omar is not inclined to do it on it.
Oh, fine.
Meanwhile, you can see the instruments too. This theater is modular, has got laminar flow also in it. You can see the instruments here.
So the DHS set is kept as a
And also we are kept as a plan B.
Okay.
If something doesn't work. We also have the general instruments, bone liver, and also we have these are the instruments that will be used for boring.
Okay, sir.
And also we have a bone graft instrument standby. We have multiple mills here. All the size of mills we have.
Oh, fine, sir.
Okay. So all the instruments are ready. Professor Margo
We
is
tell them ideally in
Getting ready
this
for
case,
the-
one minute.
ideally in this case, we should combine it with a flexion stroke. Because ideally we should combine this procedure with a flexion stroke.
Okay.
Because more healthy bone will come under the roof, and the lesion which is also lying anteriorly will go further anteriorly and inferiorly.
Fine, sir.
So I have shown you wall gastroscopy yesterday.
Sir.
If you excise a wedge of bone in a base interiorly, and then you close this wedge, that is the flexion of osteotomy, and the healthy bone will move in the weight bearing zone once the limb is extended.
So, but was there any collapse of wedge is not there? So, do you think it is needed now to do a flexion osteotomy?
I still say if you combine the flexion osteotomy, it will last the whole life.
Okay, sir. Can it be done as a second stage? Because sometimes you would not have counseled the patient.
Yes, it can be done later on also, but I generally do at the same sitting.
Oh, fine. Because you have very good results even after some amount of collapse and joint space narrowing.
Yeah.
If we can do preserve a second procedure, reserve if at all, if it is needed.
You should preserve it a stage before.
Okay.
So instead of doing flexion osteotomy third stage, do it the second stage.
Fine.
It will work the whole life.
Okay.
I showed you that patient of Nepal yesterday. There was clinically on frequent classification it was grade 2. Maybe it was grade 3 on MR.
Okay.
So actually no classification is complete. This is left side system.
Which the picket are like you mean?
Yeah, no classification is complete actually.
Fine.
There will be a lot of wider bias in classification, alpha classification, incident classification, and ticket classification also. Gangadhar.
Hello. Hello. Good morning, sir. I am Dr. Gangadhar, anesthetist, sir.
Okay.
Welcome you all for seeing me.
Thank you. Thank you.
I gave anesthesia for this patient, combined spinal epidural, for the sake of post-operative management of pain also.
Okay, so you have put an epidural catheter,
Yes, sir.
Okay, thank you.
I am giving hand over to the hospital, sir. Continue.
So we are starting the procedure now.
Good. Looking at the shock protector, AP view, please show me. Show me AP view. Yeah, it is okay. It's okay. It's okay. So please, now give me knife and keep your guide bar ready in the film. Let me do a small exposure.
We are doing with a very small exposure. Big enough to get the core instruments in. The position of the patient is supine. We are not operating on the fracture table. We are operating on a regular table.
So you got a camera person come to the right side of Dr. Marco and show, so we can see the program later on from the goes deeper. Yeah, very well.
Kato. Anjali madam. Look at that. Is that better now?
Yes, sir. Should be better. Especially when we go deeper inside. So that should be okay, sir. Now I think it's perfect.
So small incision just above and below the tip of the trochanter.
Please try to hold that.
Try to expose the inpatient.
Generally, I don't have any challenge.
Yeah. Generally, professor doesn't use any Stanley retractor or anything like that. That's the thing.
Put a guide wire in the tail.
Trying to expose the trochanter. Yeah, patient is quite bulky here. Quite a bit of fat. Probably she was on steroids for quite a period of time due to COVID. Where she might have put on
Steroids was given for COVID.
Yeah. She was admitted in ICU.
Okay.
Right handed, na? Right handed. Right handed. No, it's fine to do.
That's the trochanteric exposure. Are there any questions from that side?
Any questions?
Any questions?
As of now, nothing, sir.
Everybody is keeping silent.
Okay, sir. Is there any study or which mentions what is the maximum size of core you can take depending upon the neck diameter or something?
There are no studies which the standard there are two types of studies. One is standard core decompression and the specialty is study.
Correct, sir.
The standard core is what we take from the DHS.
Fine, sir. That is around 8 mm.
My Pickett and Arlett, Pickett designed 8 mm. Then this was replaced by simple drills 2 to 3.
Okay.
And now again, I am showing you this is the hollow mill which is of the size of the DHS diameter.
Okay. The standard core decompression is around standard DHS reprice.
Oh, fine, sir.
And the rest of it is around 3.5 multiple pins. Percutaneous drill.
See, I am not worried about the smaller size. You can do multiple times. That's a different thing. If you, we can't have one thick standard size for all the neck sizes.
Exactly.
Yeah. If we can call the
exactly
post-op practical.
Exactly. That's the downside of standard core decompression.
Okay.
You can have a subtrochanteric fracture.
Yes.
And inadvertently, if you go inside, you can violate the articular cartilage.
Articular cartilage also.
These are the two disadvantages of core decompression, standard core decompression. Whereas those things can be conveniently prevented with a multiple fold treatment.
I'm stuck up.
The some issue with the cautery and suction are the two things in any setup will give always some problem. They just held up because there's some issue with the cautery.
Okay, sir.
So that's the one. And most of the studies now with percutaneous drilling, they are doing one protein, VMAC. It's quite easy to introduce those things. This is also like some mesenchymal cell introduction only. We are taking over from the trochanter area. So it will be BMSC only. Like stem cells getting onto the region of the avascular necrosis. Gentleman here also has got an option to put the calcium phosphate granules underneath the core.
For structural stability.
Yeah, for structural stability so that some part collapse will not happen. Size of the lesion, site of the lesion. They are the two important aspects when we consider for a surgical aspect. All medially located lesions will respond well to core decompression only. The lesion in the weight bearing area, like what we have now, will have definitely some issues after core decompression. That's why Professor Mago was insisting for a proximal columnar so that the core area heals better when the normal bone comes under the acetabular root. But in some patients, the studies have also reported a secondary collapse of a normal bone which comes under the stress. So secondary collapse has also been reported.
The secondary collapse can very well happen.
Yeah. So to avoid the secondary collapse, some reports are saying drilling the collapse and putting stem cells. So these are the various options.
No, this is fine. We are still stuck up because we are changing the 40 plates.
Aftermath of COVID, these avascular on the rise, especially in young patients. There got multiple admissions in the ICU, especially after the second wave. Okay, probably our problem got solved now, so we are ready with the part and proceeding to the surgery. Okay. So we are right over the vastus lateralis.
You are splitting the lateralis or erasing it?
Just splitting the lateralis so that the
Just separating the
fibers.
fibers of the lateralis and
Yes.
trochanteric
Trochanteric
tuber.
tuber where the vastus trochanteric crest where the vastus lateralis is attached. Just those fibers are just being split. Yeah, trochanteric tuber.
problem should be settled.
లెఫ్ట్ సైడ్ నుంచి చూడేవా సార్ క్లోజ్ ఇక్కడ రా చూడు ఇక్కడ రా ఆయన ఇక్కడుండు ఇక్కడ ఇక్కడ మంచి జరుగు జరుగు జరుగుతుంది ఏం ప్రాబ్లం లేదు చాలు 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 Do you have a better view now? Santosh?
Pardon, sir?
Do you have a better view now?
Yeah.
Now you see,
Now the trochanteric tubercle is exposed.
so I am seeing the
Vastus lateralis muscles of the vastus lateralis muscles are being stretched.
Yeah, we are seeing the aponeurosis of vastus lateralis.
Exactly.
Yes.
So that area will be made bare so that we can pass the guide wire inside.
I have yet to see the image.
So getting the limb into little bit of adduction also helps to get the trochanter prominent.
Yeah.
I am not following the guidance of Dr. Vasuki. Had I followed it, I would not have to be in trouble. Oh, very nice of you, sir. Your fat is too much. Give me guide wire.
Sir, loaded, sir. We are ready for the introduction of the guide wire. Hold it properly.
Just show. I am shooting.
Yeah.
So you start at or just below the flare of trochanter?
Yeah. Trochanter tubercle.
Okay.
Press the lower.
Just press it. You won't be seeing it clear. Yeah. I'm sitting in a not proper place. Just show me now. It is a little bit. No, it is okay. Just show. Actually, I am not sitting at a proper place. Just show now. It's still down. You should pull the knee in. Show. Very close to neck. Give me another wire.
More wire.
Come, give me more wire. Show. Yeah, it is okay. Show. It's very hard now. You can feel it in the necrotic area. As now I'm passing into the dead bone area,
Sir.
I'm getting a force, resistance.
Okay.
Okay, let me see in lateral view also. How much it is going? Sure. Yeah. I'll put one more wire slightly from below, but let me see its position in lateral view. Sure. Oh, very strong. Sure. Okay. Now give me one.
That's the position of the guide wire. Can you see it on the CM images?
Yes, sir.
Now we are taking a lateral view.
Yes.
So can you show the position of the limb? How it is?
Yeah, it is central. I will make it slightly interior. I will make it slightly interior now. In lateral view.
So you do similar to what you were doing?
Yeah, yesterday what we are doing, similar position.
Okay, okay, sir.
Now the guide wire is little center.
Center, yes.
So he wants to do little anterior.
Anterior.
Okay. This. Are you sure? Just go up. No, sure. 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 You see. Sure. Slightly down. I want it slightly up. जाने तो उसको ज़्यादा ऊपर जाएगा चाहिए हाँ हाँ जा रही है ठीक है आ जाओ इट्स ओके देखा ओके नहीं लेटर को दिखाना शो लेटर व्यू
We have passed another guide wire.
It's okay.
Yeah, so that
okay.
it has come slightly nearly the lateral view.
Yeah. With this
So that
slightly to correction. Put the phone. Oh, this is.
It looks the same.
It's the AP view looks same.
Yeah.
But in the lateral view it looks good.
Okay. No, I will get the other wire I now show. It's fine.
Okay.
With other wire, the initial wire, I'll make further correction. इसको निकाल.
Where are you? Where are you?
Give me other wire.
Correct with the wiring, but don't get bent wire.
This wire we accepted otherwise. Show it to you. Show it to you.
Other bent wire.
Show it to you.
Bent wire.
Just this difference of 2 minutes.
So in the AP view, the wire looks central in the head.
I'm correcting it.
Do we need it more superior, sir, or is it okay?
Now, Santosh, what has happened is the wire is bent here a little bit.
No, sir, not the second wire. Even the
first wire itself.
sir.
Both wires are little bent. That's why when it goes to the necrotic area, is bent still further. Maybe the wires have been used for multiply used. Looks like that.
Sure. This is okay.
Now we are getting a good wire there.
Sure.
See that?
Yes.
We are coming into a good
This
position.
looks better.
Yeah. This wire is not bent.
Sure.
Yeah. This is our regular DHS guide wire.
DHS guide wire. Okay.
Just show later. So that I don't have.
Now that's the AP.
Yes.
Now we'll take a lateral and see. Yeah.
It's okay.
That's the lateral view with the second wire.
Yeah.
All of this.
So we are hitting the necrotic area. Okay?
Yes, sir.
देखो. It's very hard. It's very hard.
It means an indication that you are in the correct place.
Yeah.
Yes.
No show.
That's the second guide wire
Yes, sir.
going in a far better
Sure.
direction.
Okay. Slightly more.
Yeah, I can go it.
Sure.
Sir is literally pushing the guide. It's not going at all.
I know. Let's move.
It's quite hard. Jacob check. Jacob check. What was sir?
No. It's about 4 kilometer. Show it people now. Yeah. Now correct it. Lateral.
Now we are seeing the final position of the guide wire.
Yes.
That's the AP view. Now we are getting the lateral view. That's the lateral view.
Okay, fine.
Sir is satisfied with the position.
Fine.
Picture, save the picture, please.
So is that depth is enough for you, sir?
Depth is enough. About 3 millimeter distant to it. It should be, so it is acceptable.
3 millimeters distant
3
to
or
this.
4 millimeter.
3 or 4 millimeters distant to
Okay,
the
give me a little
subfrontal
more.
bone.
Drill.
Okay, sir.
Yeah.
Putting slightly more. See, it's wobbling. Sure? It will break. Sure. Oh no.
necrotic area is so hard. When we are putting the guide wires inside, guide wires are trying to bend. Such a hard necrotic bone.
Okay, now you give me an osteotomy. Or give me goose. I should get the entry of that.
That's what you mean.
Entry of my organ. Give me goose, curved goose. Or osteotome.
Goose.
Curved osteotome, small, very little.
If you want, we have goose.
Goose give.
Now we are trying to make a lateral entry through the trochanter, entry point, with the help of the bone pooch.
So you are planning to do with, okay, you are widening the hole with a goose.
Yeah, exactly. To put the trochanter inside.
Okay.
So the entry point around the guide wire on the trochanter area is being widened.
So the initial cortex is opened with a gouge.
Yeah, lateral cortex.
You don't use a mill to open the lateral cortex, no sir?
Issue is that if you open the mill, it will get into the trochanter and gets the some more bone out. No? So that's the issue.
Give me goose. It's okay, it's okay.
That's the recommend. So that's another point. You have to make a lateral entry wide with your gouge, not with the mill or the refine what you have.
Sometimes you can make it with the DHS also.
To preserve the bone as much as
possible. So careful that no bone goes into the DHS reamer.
To preserve the bone as much as possible.
Okay.
It's one light also. Light a bit.
DHS river.
Two forces.
As you see, there is hardly any bleeding from the wound.
The shoot on the wound.
Hardly there is any bleeding.
Yeah.
Now we are trying to open the lateral cortex with the DHS reamer.
Pardon, sir?
We are trying to open the lateral cortex because the gouge is not that sharp enough here.
Okay, sir.
So professor is using the DHS reamer to open it up.
Open the lateral.
Yeah,
Okay.
he will show the technique how to preserve the bone even with the DHS reamer.
Oh.
So that's the lateral cortex being opened up.
Sure. Image. Sure.
Under image guidance, he is doing it. Can you see that?
Okay, sir.
Yeah. See, that's the lateral cortex.
Hollow man.
Yes. Hardly there is any bone with the DHS reamer.
As of such, open.
Sir, actually, it is 10 mm.
Huh? This is a 10 mm.
Yes, sir.
And that is
The smaller also. Now you use one that is small
Yes, sir.
size.
There is a question.
why
So
don't
we
you-
have our own, we have our instruments, sir, that is reamer, sir. Drill bit is there, sir.
Okay.
Marking.
Can we use this also? Can we use this?
So we enter our search చిన్న size. ఇది పెద్ద ఉంది, sir.
वैसे कोई फर्क नहीं पड़ेगा इसमें.
Give your reamer.
Yes, sir.
अरे मेरे ना.
Yes, sir.
इससे हम बोन ले सकते हैं वैसे.
Yes, sir, ले सकते हैं.
ले लें.
But it won't impress, sir. It
Wait,
is
wait,
size
wait.
थोड़ा
It's slightly broad.
Yeah.
Right.
సరే
use it. That was okay. How? Give me the hollow mill.
Now the hollow. అక్కడ ఏం రాదా పిక్చర్ రాదా
ఇక్కడ వస్తుంది మోడల్ బాగా
సైజ్ అయితే మీరు చూసి
ఫోన్లో మాట్లాడండి.
షో
అక్కడ చూపెట్టు
Now take a tray and wet sponge. Put the wet sponge.
యాక్చువల్లీ 8 mm అది 10 mm మా ఇన్స్ట్రుమెంట్స్ అన్ని 10 mm.
ఓకే 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 ఇప్పుడు అయిపోయింది కదా స్టెప్
Yeah, sure. Now it is very hard. Now you apply force. Come at my, yeah, do it. In this direction.
Hello, Santosh? Hello?
Dr. Vatsky, hi.
Can you hear?
Yeah.
Yeah. Okay, fine.
Dr. Ravana.
Oh, good sir. There's some
One question.
Yeah.
We are going with a. Hello?
Yeah. We can hear you. We can hear you.
Hello?
Yeah, we can hear you.
I was using a narrow one, but he has given me broad DHS. I wanted to use a narrow mill.
Hello?
Yeah. Dr. Ramana, can you go ahead with your question?
For very close to the superior part of the neck.
Pardon?
No, it doesn't matter. It is very nice. This is the ideal place.
Yeah.
If this is nothing is going to happen, don't worry.
So, would you like to take a entry point a little more distally and go into
That
the
depends
head?
upon you. As you go more distally, stress area is considered there, and there are fractures. So here you will get good bone also, and no stress fracture, because this is the intertrochanteric area.
No,
So
no.
more the lower down you go, more chances of stress fracture subtrochanteric. Okay, just a minute. Now I am taking it out. I am taking it out. Hold it. Oh.
The hollow mill is inside. It has gone just at the level of the necrotic area. So he has taken out the hollow mill.
I come. Give the
Now the graft
Salad.
from the trochanter area.
give the salad and hammer. No. ये देखिए ये देगा salad. ये देगा मैडम छोड़ो. आगे सट जाओ.
You are able to see, sir, we wanted to know how much graft we have achieved.
Yeah, that's the thing.
Hammer it up. On this side. Come on this side. Yeah.
So what's the diameter of the core?
Let me hold it.
10 mm.
Slowly. Hammer. Yeah.
Now the core is being pushed out from the mill.
Push.
Yeah, we are able to see.
Yeah, see the core?
Flux have come out. Yes.
Yeah.
This is still osteoporotic, but you see this white area is dead. This white area,
Yes, sir.
this is live, this is dead.
Okay, sir.
Okay. And I could have taken more also, but that required force. Now I will remove this dead area with a reamer. DHS reamer.
DHS reamer.
Yeah. Okay. And I will take more graft from the trochanteric area for this lady. Still the graft is actually less.
Oh, fine, sir.
Okay.
So the same incision you will take the graft, further
Yes,
graft.
same incision.
Same incision.
So the mill has gone up to the necrotic area, up to the border of the necrotic area,
Show me.
Okay, sir.
and the graft has been
You
taken.
show me little. Again you give me the copy.
Necrotic area will be done by the
Yeah, debridement of the necrotic area.
Fine.
Graft has been harvested, now the debridement.
I'm again trying if I can get more.
It is very hard. So he is trying to get one more, or if it is possible. Okay?
Sir, it's
My
really
assistant
pushing
failed.
hard there, we can see.
Yeah.
My assistant failed to get. Show. So, okay.
Whichever. Possibility. That's good. See, the young man is pushing the mill hardly inside. Come on, push.
Show. Picture.
Picture. Now we are in the door area.
Wire is bending.
Wire is bending. It's really hard.
Really hard.
Really hard.
The wire bent. Okay,
So
doesn't
wire
matter.
bent and
You take out the graft wherever possible.
Yes.
Can you do it? Hatu, छोड़ो.
You see, if the necrotic area is really hard, and on the CM images you are seeing, the guide wire is
Getting bent.
getting bent. Actually, it backed off with the myth. So we need to reintroduce the guide wire into the area and really curate that necrotic area. We got one more graft. Yeah.
Take a plier.
You are able to see the graft second?
Yeah, we are seeing the mill now.
Push. Push if it is there. Yeah, push. 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 Come fully. Yeah. We have got more. See, now this is complete white, you see?
Completely white.
You are able to see this? It's completely white. Still some live graft is there. Okay. We'll use it in the trochanteric region.
Okay.
And we'll use this in the head region.
Head region.
Now you give me a reamer. Reamer and guide wire first.
Can you see that core area?
Yes, you can see the progress.
That's the
It looks more than 1/3 of the next step. That is what we were worried
That's
about.
the track.
I was using a small mill, but he has given me purposely. I don't know why he is using. In my hand, I had narrow mill, but it doesn't matter. There are so many mills. The small mills are used for younger age group children.
Indian females will have a very short neck sometimes.
Yeah. No, we have got different size of course.
In the morning when the company person was showing that EMC company, whichever we have, he has only one size of the core.
That is the core what we have used.
Okay, that could look large here.
Yeah, so be careful.
Okay. Confirm it now.
So that's the AP and lateral view. Okay?
Sir, yeah, look fine.
Reamer.
Yes, sir.
Now the hard bone, I will use reamer to do the debridement. Okay?
Yes.
Show please.
So he's using the DHS reamer.
Show.
Sister, DHS reamer.
DHS reamer. And the medially. Show.
So with this reamer, you go down till the subfrontal bone.
Yes. So the necrotic area.
Fine. Till the tip of the third one.
Yeah. See the tip of the. See it is progressing slowly. Can you see that?
Yes, sir. This is power reaming.
Yeah, it's like that.
In a drill mode or reaming mode, sir?
It's in a reaming mode.
Okay.
Nice.
Sir.
Yeah. Now you get
Opening blades.
Nice. Great.
Now we have finished that reaming of the necrotic area.
Fine.
Yeah. You see the track again?
Yes.
Can you see that?
Yes.
Yeah.
So now you ream with the knife.
Pardon, sir?
The blade you look like blade knife, which is meant to debride that. I'll show you.
Sir.
So he's going to use the
That company blade. Proprietary blade.
cover padega.
Anyone in the audience there use a flip cutter? Vasuki sir, have you tried flip cutter?
No, we have not tried.
I don't have one, or else I have tried it.
We have not tried. Now he is using that flip cutter.
There is one flip cutter from Depi also.
Yes.
Which has one flip cutter can be adjusted to multiple diameters.
Exactly.
The amount of opening it does, like how it is. Yes, sir.
Now see the flip cutter.
This is a hand flip cutter.
Yeah. The flip cutter is assembled. Now we are going into the core area with the flip cutter on.
Can you see a picture, sir? We wanted to see.
So the CM picture.
Show the image.
Can you see that?
Okay.
On the image?
Now I'm cutting it.
Now the flip cutter is open.
You see?
Fine, sir. Yes.
See? Yeah.
Now he is trying to flip it.
To get it the bone around.
Can you see that? One is open, one is closed. See that?
Yeah.
It's opening and it is closing. So that's the debridement of the necrotic segment.
The question is that is just a blade, sir, which is turned around. Will it really cut the hard bone or it will bend?
I think it will cut the hard bone.
Okay, sir.
Cut the hard bone.
Show.
How is sir feeling the resistance when he's doing it?
It is
If it is easy, then it is not cutting the bone for sure.
it is, no, it is cutting.
Oh, okay, sir.
It is even crackling.
Okay, sir.
Show.
Can you see that?
Yes, sir. Yes. Sir, do we have a die present? Can we see it?
Pardon me?
Can we have a die and see?
No,
Put a
we
die
don't.
and see.
We don't have a die.
See now? Show. Show.
He is having that typical crackling sensation.
Fine, sir. Fine. We agree with you. You know, just as a objective evidence, I was asking.
You're right.
Wash. Let me have first wash. Okay, I'm using the curate now. You see the curate? See the curate?
X-ray. The curate is on into the necrotic area.
The next curate. Okay, sir. Fine.
Where is curate?
Take it. Keep it in the preventive area. Just take it.
Sir, इसको Only a mechanical view. So he is curating that area, necrotic area. They're getting more bone. Necrotic bone is coming out. See, he is holding in the curate. Can you see that?
Yes, sir. Yes.
These are the necrotic bones. They can be packed in the trochanteric area.
The trochanteric area.
Will do. Water తీసుకో 50 ml syringe ఇంకో 50 ml syringe తీసుకో రెండు తీసుకో త్వరగా ఇవ్వు స్పెల్లింగ్ లేదా
Spinal release, I think.
No. It is better he had an odor. You have? Keep it there. Syringe.
Here,
Give me syringe.
syringes.
Grab this one. You can keep this also.
Please.
इसको
For
निकालो.
washing. This is the plate. Give one.
No. Any other tube? Any other? Give me the hollow tube.
Hollow will you buy?
Sir, okay. Can you show that defibrillator from outside? That,
Yeah.
The constantly from whatever blade you have.
Yeah, 1 minute will show you.
If sir finishes washing,
Yeah.
we can
Yeah.
see.
बहुत पतली है. This kind of shape. ले लगाओ.
Hollow will
ले लगाओ. Put the kitchen there.
Sir, another option is to put a Niles tube or a suction
Yeah,
catheter
that's
inside.
right. Put a nice tube and wash it. So the necrotic area is being washed.
Yeah. So ask the cameraman to show that this is the
Yeah,
defibrillator. Yes.
Once we finish this,
Give water.
How it opens up also we need to see, sir.
open this pedal.
Dr. Vadaprasad sir can show us how it opens
Yeah,
up.
you need to see now.
Yes, we are not seeing. Yeah. Now we can see. Yes.
See, that's the clip cutter.
Can you zoom out a little?
Yes. Zoom out
Yes.
again.
Fine. Fine.
That's the clip cutter.
Yes.
Okay, now he is assembling the clip cutter into the nozzle. Can you see that?
Okay. Sir.
Yeah.
Okay. Yes. Okay.
And then where is that? And now, what is this instrument?
See the image?
Decompression blade, sir.
Show image.
This is
Show image.
the holder, sir. See that holder is being put onto the.
Okay.
Now, sir, can you see that?
Yes.
Yeah.
Yes.
Now give me blade again. Give me cutter.
Once I have to clean this. He is cleaning. Lot of bone is there inside that nozzle. 1 minute.
Show me the tag now. See, it's clean. I still want to clean more in the subchondral area. Must be in my
Yes. Now we are seeing it.
Yeah, that's the
Okay.
metal being loaded.
So it can protract and contract.
Yes, exactly. It will wind round like a fan blade.
Give me cutter again, blade, please.
Sir wants to use it again. Yes.
Yeah. Cutter is going again inside.
Show.
Can you see that now?
Yes. Inside.
See that?
Further in now.
Show.
That's the blade opening.
I'm cutting spinel. Show. Show. Cutting inferiorly. Show. Show. Show.
I think when the wire, the blade is coming out, the stem is coming back.
Slightly it should come, otherwise it will break.
Otherwise the blade will break.
Yes, sir.
It doesn't come.
No, it's a very hard bone. I don't
Yeah,
think
yeah.
that blade will go into
No,
the bone,
no,
penetrate
no.
into the bone
No.
easily. Once you start reaming it, then it will happen.
You see that? That's the depth we have.
Yes.
Show.
The in vitro, how much it protrudes out, in vivo it doesn't not open.
Yeah.
Now you show. Now I made a place, now I will go back. Okay.
Now the slot has been made with the cutter.
Yes, sir.
Now we'll go back and little bit get the depth in.
Yeah, now it is opened quite nicely.
Yeah.
Just see this one. Yeah. See.
Okay, this is a problem.
Yeah.
It's hard.
It's quite hard.
Show.
Definitely, sir.
Yeah.
Officer is exercising his biceps,
Yeah.
biceps, everything. Yes.
Now give me wash. Show.
Wash and then train it.
Wash. So you take out this dead bone. Take out this dead bone.
Yes.
Give me wash and a tray. Please don't waste time.
The repeated debridement, repeated washing requires quite a bit of patience.
So what will be the end point clinically?
Yeah. That's right. We are trying to get the people out of that.
So there is a lot of hard bone, I believe, in that blade.
Yes. There's not
All the soft tissue also is
What? Go. Now it's very clean now. Is it clean or should I do more?
What do you think? End point?
Joe? End point is that you should feel reasonably up to 3 mm of the subchondral bone, it is debrided.
Okay, sir. Fine.
And now you see here, the good bone has been debrided. Show good X-ray, good image.
Yes.
Good
Yes.
image. And close up.
Yeah, we are able to see, sir.
Because whenever you use cutter,
Sir.
then that bone comes in the mill.
Okay, sir. Fine.
So then you feel satisfied, yes, now it has been done. Now again I am washing it and I may use a curate. See? Curate. Now again I am curate. You see, put the see. So here you have to be very careful. You may not fracture the bone. See this. See?
Yeah.
Good morning. Show. Now I am putting the graph, okay?
Fine, sir.
That is fine.
Sir, do we need to drill with smaller drill bit till the subfrontal bone?
You can do.
That we can do on this.
Yes, you can do it, but I have not done it. That's the kind of innovation. And okay, yeah.
Chances that the drill bit might break so hard inside.
Yes, sir. That might be possible. Yes.
So it might be. Correct.
Sir. You remove my specs, whatever you like. Come from this side. You remove my specs and properly place me here. इसमें पहले लाइट में डाल दी.
The core of that bone grafting pushing class will not hold our core actually. The diameter of that bone graft, whatever the company person is holding there, Kishan agree, it will not hold our core there. Because our core is quite larger diameter.
No, he has some more also.
That will hold muscleized bone only. That will help us to put a muscleized bone rather than what sir usually puts.
Yeah, difficult to put the core inside.
He has other reamers and other core mill also of lesser diameter.
Sir. Now, how will you put that? We want to see how will you put that core one.
I am showing you.
Yes, sir.
Okay. Now this is the funnel. In the funnel, I will put the grafts. You see, this is the hollow. Show camera. You see, this is the funnel. Is it? And you see, this is the piston.
Yes, sir.
And there is a hollow. So I'll put the grafts here and then push. And put the grafts and push.
Yes, and push. Okay. So you don't put that core in toto, like push it back. You put it in pieces.
You can do it, but they break.
Okay, sir. Okay.
Whatever I say, this is line also. Four circle. Four circle. In the halwa.
You able to follow it, Prakash?
Live graph. Take the live graph from here. Let me
Same graph.
Scissors. Take the scissors. This is white.
So this is the reverse core basically.
Reverse core.
Yeah.
First, good cancerous bone followed by the hard bone.
Exactly. The good cancerous bone goes into the necrotic area. Hard bone comes in the trochanteric.
Okay.
So whatever the mesenchymal cells present in that
Trochanter will go inside.
So it can induce the angiogenesis.
Yes, definitely.
And helps in repair.
They're all life cells.
Yeah, helps in repair also gives a structural support. It reduces the pressure also inside.
Yes.
Whenever there is a heavy bone marrow edema, the trochanter area,
Small.
all the areas also show good amount of edema around the trochanter area and around the upper shaft area.
So that bone is
So in such situations, better to avoid this type of decompression.
The only worry, as our senior doctors were also telling here, is the thickness of that core and coming into the tensile aspect of the neck.
Exactly. That's what it's really dynamic quite difficult. Yeah. For this neck.
Yeah, for this neck, yes. For this neck.
So we have to be quite careful. So whenever if the MRI shows an extensive edema of the upper femur,
Very good.
apart from the avascular necrosis, yes, this type of core decompression should be very, very careful.
Yeah.
Because there are chances that the edema and osteoporosis can cause a fracture.
Yeah.
So probably in the quiescent stage,
Yeah.
this core decompression will help.
This is dead bone now.
There's no need to
Break it.
Remove core and all.
Yeah, there's no need to jump in and do a core
In the
decompression when there's an extensive edema of the upper femur.
Yes, sir. Yes.
then we'll end up in complications.
Let the player go.
So that's why we initially treated this lady with rest, chronic pain, and calcium supplements, physiotherapy, and vitamin D. Her pain factor progressively came down.
Did you start on bisphosphonates
No,
or
we have not started on bisphosphonates.
you didn't start that?
We have not started on bisphosphonates.
Every bit of it.
We have only now that the patient is not on steroids,
Sir.
and also her general condition was not that great.
Good move.
Fine. Also, she has put on a lot of weight, you see.
Yeah.
The thigh is really bulky.
Oh, okay. So we can also take more grafts from the trochanteric area. So if you feel like, you can also use calcium grafts. The calcium graft you'll put subcontinental if you're using or? No, in the trochanteric area. Generally I don't put. Okay, sir. Okay. It's a source of infection also, you see.
Sir. The track also contains a lot of clotted blood, you know.
Sure. Pardon, sir?
The track also contains a lot of clotted blood.
Correct.
Which also has got a little bit of good viable cells.
Sure.
Yes, sir. Like a PRP.
Now you see, I'm withdrawing it.
Better than PRP.
Sure. Little bit of it. Because you see, graft has gone.
Okay.
See, sure.
Down.
Hammer.
On the camera image, it is not so clearly visible, but I think it should be visible there.
अरे यार मैंने करना थोड़ा सा देखा शो या ब्रेक नाउ ब्रेक शो या जस्ट और शो दिखाओ डाल हैमर कर दिया
Sir, question here is, can we put a fibular strut? That is better or this is
यार नहीं यार दिखाओ ना बाहर है
अभी आ रहा है.
प्लीज डोंट एक्सपीरियंस दिखाओ और दिखाओ हैमर या प्लीज
So the graft is going nicely inside. Sir, yes, beautiful. Just seated just below the subchondral bone, very nicely.
No, still stuck up here. Yeah.
So the question here was like, is this graft better or fibular strut graft better?
छोड़ो करने दो करो या दिखा या और करो तो और डाल सर piston should come na piston is not come yeah sure yeah
Now you see the core is not the graft now. Filled with the graft.
sure yeah
You see that?
the piston is still coming
The piston is coming out. Yes.
दो से हो गया the piston has come out I think so karo yeah the piston is
The
out
piston is come out and the core area is filled with the graft. Can you see that?
yes completely
Yeah.
proximal half of the
Proximal, yeah. The neck portion and the
head portion
head portion is
show
filled.
good picture yes
Now you can see that picture?
yes sir, yes up to the basic cervical area it is almost there
Yes, sir.
now you can take some graft from the trochanteric will you show trochanteric yes cure it
Some more graft from the trochanteric area.
now you see here
Yes, sir.
so I can take some graft more with curate and can fill in the area or you can take calcium graft or the fibular graft is avascular and generally causes some infection sometimes. So these grafts are not floating grafts. These grafts have been packed. They are not going to come back.
They are not going to
But
come
if you
back.
feel that the bone is weak, then you can put fibular graft half split also.
Okay.
Show me.
That's the answer for
Like
it.
this, you can take, you see. Show, no. Show please. Show. Yeah, you can take graft from this area. Yeah.
He's curating the graft from the trochanteric area. You see?
You see, this is good graft. And I'm just showing them.
The graft is
Okay.
That's the bone graft which is related to the
It
trochanter.
doesn't require actually. Even osteoporosis. Okay, it's fine. Possible. Now you just close, no negative brain. Muscle will fall. You just stick the tensor fascia lata. This is tensor fascia lata.
Okay.
And this is tensor fascia lata. Close. And then double layer fat.
So have you any time combined both the grafts, sir?
Yes, I have combined. I showed you yesterday. I showed you yesterday. I have combined it. But it slightly enters the strengthens the bone.
Yes, sir.
You may add, you may not add.
Okay.
Definitely, in an osteoporotic bone, it may be better to prevent the fracture.
Okay, okay, sir. In the immediate course of-
And all these fibrographs are incorporated in my cases. In one case, that got infected and I have to remove the fibrograft.
Oh, okay, fine.
So the final X-ray.
The patient was in anesthetic from, he came to me from Ranchi.
Use instead of using a 10 mm 40.
It is 8 mm.
With 3 mm.
It's probably 8 mm. It's 8 mm. कितना diameter है इसका?
10, sir.
The other one was of 8?
Yes.
So I used 8 mm.
Good 3 mm. Some people are using.
They all depends on the size of the neck and size of the lesion.
Yeah.
Finally.
Yeah.
It boils down to the size of the neck and size of the
neck
and the necrotic area.
And the necrotic area and the age of the patient also.
So the question was, smaller drill bit, multiple drill holes is better or a core decompression is better?
This is better, but I have shown you. Small drills, you don't remove the necrotic area with small drills.
Vasu sir, will you be able to put a graph with a smaller drill bit?
That's the issue. You can't put this entire core graph there.
Okay.
The small drill. He's asking, can we put this small drill with the core with small drills?
No. You cannot do it. We cannot.
Yeah. What will be the post-op protocol for this patient?
Post-op protocol.
See, post-operative, yes. The patient, the lady, she can sit next day in the bed and she can walk assisted with the walker, go to the toilet, and after 4 weeks, she can walk with a stick.
Which toilet she will use? Indian toilet or Western toilet?
Yeah. This question is very difficult.
This is the important question now.
It may be Indian dollar in the side, but she should use Western dollar.
Yeah, yes. I know spot cross-leg setting also.
I tell you, you know the answer many of the questions, but
So I think we are done with the core decompression.
Yeah.
So somebody asked, you should eat rice. The question was, sir, Vanaspati rice or other rice?
Basmati rice. I think we all give a good big applause to Dr. Babu.
Yes, sir.
Yeah, for that.
There is no chance of fracture because the calcar is very strong.
Thanks a lot, sir. Thanks a lot.
The calcar is intact. There is no chance of fracture. But we should always presume and anticipate that it can still occur.
Yes. We should take all precautions from our side also.
Absolutely.
Professor will come outside and answer your questions.
Yes, sir. Yes.
Thank you from the theatre. Bye-bye, that's it for the live demonstrations.
Thanks from all the OT team.
Thank you.
From our audience here to all of you. Thank you, sir.
Thank you, delegates, and thank you, Santosh. Professor will come out. Thank you, sir.
Thank you.
Then we'll go back to the workshop.
You are charging more money. Even in Max, we charge 20,000, and that is 30% surplus to the patient because they record the instruments. So in Max, we are charging only 12,000 including everything. So you are charging.
Also, the delegates want to speak to the implant person also once he comes out.
Yeah.
You want totally dedicated like same individual
ఏం లేకుండా మనం ఏం చేయలేం. మరి మనంతా తుస్సుగా తెచ్చుకొని పెట్టుకున్నాడు, 50 సార్లు దొరుకుతాడు, చెప్పుకొని దిగాడు అంతే. ఏం లేకుండా మనం ఏం
Excuse me? Professor, we're demonstrating the workshop for you guys. After that, you can go.
Not leading us perfectly.
Going back to Guntur. No problem. Thank you for the
क्यों लगाइएगा ये इस तरफ क्यों लगाइए
मसाले वाला and you see, you have the angle of anti-version. So insert the wire first along the anti-version, that is the anti-version wire, so that your blade goes accordingly. And you mark the trochanter, sign pen. So you mark the trochanter. This is the trochanter tubercle. That is the most common point where you make your window for the blade, okay? And divide it into 3 parts: anterior 1/3, middle 1/3, and posterior 1/3. You see my I show you. This is anterior. Yeah. This is anterior 1/3. That is the middle, and that's the posterior. That's the lesser trochanter. Okay. So select a junction of anterior 1/3 and middle 1/3. So this is the. This is anterior 1/3 and middle 1/3. Is okay?
Yes.
Okay. So this is, you make the track here. Most of the procedure you have seen my slide also. I don't think it is difficult for you to understand. Anyone, you can do it. And the beginner should first assist a surgeon or call a surgeon who's done few osteotomies so that you don't err. Once error is there, blade is cut through, then it is difficult situation to handle. All of you are having good OTs and all of you are having imaging OTs. I rather than that. So इधर से है कि वो दूसरी आ गई. So this is the angle of anti-version. So you put a wire as per drill. So you have done the lateral NCM, you can feel the trochanter tubercle, you can feel the anterior surface, and first wire should be the anti-version wire. It is written into the manual also. In the bone it is easy. And gradually you will feel that there is no need to pass it. But that is how I learned after reading your manual in 89 and learned it from Professor Holmes in Germany. Those days nobody was doing osteotomies. Yeah, very simple. Okay. Fashion नहीं करना, everybody can hear me. So this is the lesser trochanter. It is visible to you in AP view under image. So the osteotomy is intertrochanteric. That is between the greater trochanter and the lesser trochanter. So just above the lesser trochanter. So give me a guide wire. I am giving you an exercise of exercising the bed of 30 degree. So put in the drill. Put it on the drill. It will be above. Take your hand. Okay. And this should be 1.5 centimeter
distal to the entry of your blade. Then for the reason, simple reason, that this elbow is a 15 millimeter. At times this can be 20 millimeter also, as per AO instructions. So we are using 15 millimeter, okay? So this is the track. Here you are going to get the track. So this is the proximal limb of the osteotomy. So let us have the distal limb of the osteotomy, that will also be above the lesser trochanter. This is above the lesser trochanter. So defining a wedge of 30 degree, as I told you yesterday, this is 20. So is 30? So yes, this is 30. So I told you for a blade plate of 120 degrees, the supplementary angle is 60 degree. So if you want to excise a wedge of 30 degree, so 60 plus 30 is equal to 90. So your flap will be at 90 degree. Dikhaiye.
Yeah.
Yoshi.
Sir, yeah.
No?
Yeah.
This is, you should understand.
Yeah, this was.
Yeah. This should be at 90 degree. And that you can define. Where's the 90 degree? Yes, this is 90 degree. This is 70 and this is 90. Yeah. This is 90 degree. When you tighten it. With AO chisel, you can use a screwdriver also from there. The other side, you can put a screwdriver. And on the other side, you can put the socket wrench. Socket key. Yeah. Is it okay? So this you have to do the assembly on the table. As your chisel makes a track into the neck of the femur, you are keeping it parallel. You see the blade will form an angle of 30 degree. And as you excise a wedge of 30 degree, you can easily approximate your femur to the plate or plate to the femur. So always apply bone to the implant, to the plate, abduct it. Otherwise you may apply force on the plate and that can cut through from above, okay? So with this you now, so let us make a window for this. नहीं अभी तो स्टार्ट में बताएंगे ना इसकी ट्रैक बना दो पोस्टोटॉप है भाई क्या तुम्हारा तो इसको कैसे बनाओगे ड्रिल करके बनाओगे ड्रिल बिट है क्या इससे बनाओगे सर पहले ब्लेड डालते हैं फिर उसके बाद करते हैं या जैसे आपका मन करता है things are not going to change. Then you can insert it. Otherwise, this will teach you also. You only did it.
तो अभी जो बैटरी डाली है
You tell me. So that your blade can penetrate and can see it also. It's all solid. It's all solid.
लंबी स्मॉल अस्ट्रोन भी छोटा पतला होता
It's all masala paint. So normally you don't have to stress.
Sir,
So see, you define your, so many ways you can do the accurate calculations, like with your flap. So this is one help that you are going to accept at 30 degrees. Wires, other help. And template is the third help. I showed you, this is 20 degrees. And this is 30 degrees. So this is 30 degrees. So this is the wedge you see here. Give me a guide wire. ये कितने की है यार जोशी ये जो है
पता मंगाई है
So this is second interval. You see. Okay, now it's above that set of entry. Okay, so this is the wedge you have to find. Okay, sure. You will put a third guide wire also, which is parallel to this lower and this for 30 degrees. Okay. So that will come in the way. So let us put now something we should put to the inside. ये निकालते हैं इसको तो साउथ पेपर साउथ होगा let us we have done this put your chisel inside. We have done this, pass the wires after we put the chisel inside at 90 degrees. So that the lead reacts. So we want to do it now. We can remove the wires to facilitate our achievement. Can you move it? You can also this will break otherwise. If I don't do it, it will break. Let us make a track for it fully. So this may not help. This is quite wide. This masala ball will break. So we saw there is small area. It depends.
చుట్టుకొని टेबल इसलिए लगेंगे सब इंडिविजुअल खड़े होते हैं डॉक्टर्स खड़े होते हैं సార్ చెప్తే మీకు అర్థం సార్ పట్టుకోబెట్టాను दिल्ली कौन ये ओके बेटी पिक्चर आप बना very nice. Anything else? खाने के बाद बिल्कुल
More With these two instruments, you don't have to take a battery of instruments for your reverse bone grafting area. Everybody has the DHS set. Okay? So this is the bone mill or hollow bone, and with this you can take the graft as you saw me during surgery, and this is a stellate, and the graft can be taken out. With DHS you can remove the dead bone and use these two tools. The graft which you have taken, yes, for a cutter, you purchase cutter. That cost is daily 3,000 rupees. They give me 3,000 rupees. With 3,000 rupees you can do 5 surgeries. With that bone cutter you can do 5 surgeries. And 5 surgeries, so use this mill. Same company? Yes, same company original. You have the cutter? इनके पास नहीं है. You can propose people or you can help you. तुम्हारे पास नहीं है वो है नहीं. They can purchase and give you one discounted one. In fact. So do this. Use your drill and very carefully with the loop you remove the dead bone. And then you put the graft and insert, take it into the head and use this piston. So थोड़ा सा जो मेरा बना के तुमको दिया है I use there at times original one. Most of the times at Rohtak I use there. I do not get these very high-headed and very high-headed instrumentation from any company. They are made, I have used locally for alien also. And I will send you the picture. Those picture may be there in my laptop. I will send you the picture also. Give them also. तुमने बनाई थी ना, तुमने जलंधर में दिखाई थी. Yeah. You can sell it very, very simple, very cheap. Dr. Vasuki, chale kya? There was some fault earlier in the plate. Now it is very good.
Javed नाम है Javed हाँ Javed come the certificate
Okay, thank you. Okay, thanks.
Sir, look here, sir.
Right. Thanks.
Okay, sir.
Right.
Okay.
Thank you.
Ready, sir?
Okay, sir. Okay, sir.
Santosh, certificate. Sharma PS. Sir, CS Corona time.
Okay, sir.
Hello.
Sir, thank you so much.
తీయలే సార్ నేను అయిపోయిందంట ఇంటికి వెళ్ళాను అది అయిపోయింది అదే తీస్తాను ఇంకేంటి మళ్ళా చెప్తారు ఇక అది ఇంకేటి వస్తున్నావు అది ఇంకేటి ఇస్తావు పోన్నాను వాళ్ళు 5 నిమిషాలు నిలబడం సార్ 5 నిమిషాలు అసలు ఇది మనం అయిపోయిందంటే మళ్ళీ అడగచ్చు చెప్పినాడు అన్న వెయిట్ చేద్దామంటే చెప్తాను థ్యాంక్ యూ అంటారు మనకి ఇస్తారు వాళ్ళు కూర్చో బా కూర్చో కూర్చో
సార్ తినే ఇప్పుడు
ఇలా దీనిలో మన బ్యాగ్
అందుకే కదా
See you soon.
అడుగున్నావు మళ్ళా మళ్ళీ మేము అదేగా చెప్పినాడు